Anna.
Thanks, Anna.
Well, thank you so much, and welcome everybody. This is actually another live episode of Heart to Heart with Anna, recorded right at Methodist Hospital. This is the second one. I did another one earlier this month with Dr. Lynn. It was very exciting. But today we are here at the 5th Annual Adult Congenital Heart Symposium in Houston, Texas. So today we have a panel of experts, and I'm going to start by having each of my experts introduce himself or herself to all of us so that we know why you are here. And we'll start with Boone.
Hello, everyone. My name is Dr. Abu Abu Loma. I'm the curriculum developer for our DeBakey CV Education, and that's the department that coordinates educational programs such as this one for our Heart and Vascular Center. Why I'm here today, over the past 3 years, we've worked with Dr. Lynn to engage as well as educate adults living with congenital heart disease. We've done focus groups to really understand what the needs are and tailor symposiums such as this one to those needs and provide education as much as we can to caregivers as well as providers in ACHD.
Hi, I'm Ari Cedars. I'm an adult congenital heart disease physician from the University of Texas Southwestern up in Dallas. I've been on Anna's show before, and I'm here because I've had the good fortune to be a part of this symposium since the very beginning, and I think it's just a wonderful forum for patients and providers to come together and speak about adult congenital heart disease with the goal of raising awareness in the community at large, both among physicians and among patients, of the important issues that there are for congenital heart disease patients.
Hi, everyone. My name is Eunice Carranza. I am a nurse practitioner here at Houston Methodist. I have supported the adult congenital heart program here with Dr. Lynn. My role and why I'm here today is I help onboard new patients in the program, help with patient education. I also assist with education on the staff level, on the units. And most importantly, my job is to keep our patients safe and to get them home timely. Thank you.
Hi, everyone. I'm Ashley Reef. I am the nursing coordinator for the Adult Congenital Heart Program here at Methodist. And similar to what Eunice does, I help educate our patients as well as staff throughout the hospital system. And I have been lucky enough to have practiced in the beginning of my career as a pediatric CVICU nurse at Children's Hospital in Philadelphia. So I have taken care of congenital heart patients across the lifespan.
Hi, my name is Gary Montero. I'm a cardiac anesthesiologist here at Methodist, and I support the adult congenital heart program. It's been an interest of mine ever since I was a baby resident. I pursued a pediatric cardiac fellowship after my adult cardiac fellowship, and I support Huie in the cath lab, and whenever his patients need to have surgery, and the adult congenital program in the operating room setting.
Hi, I'm Chris Donald. I'm a pediatric cardiology nurse in West Monroe, Louisiana. I'm also a hypoplastic right heart. I'm 26 years post-Fontan. I have a 14-month-old son, and I'm here today.
And Joe, we'll have to end that with you.
Hi, I'm Joe Valente. I'm a board-certified patient advocate, independent patient advocate, and work with adults and children with congenital heart disease here in Houston and across the country. I'm also a patient with tetralogy of Fallot. Have had 4 open heart surgeries and am seen at Texas Children's. And I love this event. I think it's great for the doctors and especially some of the primary care providers to get their feet wet with the adult congenital heart disease. And I really appreciate being here.
Great. Well, next I would like to know what your biggest challenge has been in dealing with congenital heart defects. And I know people like Chris and Joe will have a different perspective than what the professionals do. So we'll go ahead and start with you, Joe.
I think the biggest challenge has been kind of keeping up with the evolution of the care. You know, I'm 37 years old, and kind of as we saw earlier, just looking at the statistics of what medicine knew about us 20 years ago, oh, we don't need to replace your pulmonary valve. You know, having free PI your whole life is fine, to then, determining that it's an issue and we're going to change the way we do everything. So being a part of that evolution is pretty fascinating, and to being a patient and being really involved in that, to kind of see that evolution is really interesting. And I think a lot of us think we're in the 21st century and everything is figured out, and this is definitely an arena where there's more things we don't know than we do know, and being able to see that and really realize how primitive we are in this, it's a testament to how hard these doctors and researchers are working to really try to figure out what we're doing. And I think the patients and the doctors and everybody working together, I think we're really setting the trend and improving outcomes and improving lives.
So from our experience with on the educational side, over the past 3 years, when we've tried to engage patients as well as caregivers, we've noticed one of our challenges has been really engaging those who are not symptomatic. So Anna, if I could share your experience a little bit. When Anna and I were talking about a week or so ago, it's really engaging the younger population who have been used to their parents sort of, taking ownership of their health, and then now they're not symptomatic and they're thinking, well, maybe I shouldn't have to follow up with a cardiologist. So really engaging them and saying, okay, be more proactive, go see your cardiologist, even if you're not symptomatic, and also keep up with the new advancements in this area of work prior to needing an intervention. So I think on the fundamental level is really engaging those who have CHD to just make sure they're keeping up even if they do not have any symptoms.
I love that answer. That is so awesome.
So I approach this from the physician's point of view. I think the greatest challenges that I've experienced have been two. One has been to get institutions and funding organizations interested in ACHD as a field, which is viewed as kind of a small group of people, not a big ticket item. And so from the level of writing manuscripts and getting them published in big name journals all the way to applying for grants and trying to get funding for research, there's not a whole lot of, or to funding a program like Huie is built here at Methodist, there's not a lot of interest in putting resources into congenital heart disease. I do believe this is changing, and it's a good thing that it's changing, and it's symposia like this that I think are at least in part responsible for that change in attitude. But that's been one source of frustration. The other source of frustration is one that I don't think is only the case in congenital heart disease, and that's that a lot of medical research is focused solely on what are hard clinical outcomes, mortality, hospitalization, and I think that it's an underappreciated fact that the patient's experience outside of the hospital when they're not in the doctor's office, and trying to optimize that should be one of our, if not the primary goal of care. In particular, when we're talking about people living with a lifespan of disease, they're born with congenital heart disease. This is your life. And for us as providers to be able to tell patients that, yeah, you can exercise, you can play sports, you can have children, you can live the life that you want to live, and to enable them to do so should be a greater focus of our guidelines and our research than it has been.
Yay, yes, oh my gosh.
So, as a nurse practitioner, there's so many things I could talk about today as challenges, but I'm going to pick one that's very important to my role when I receive a patient in the clinic, and that has a lot to do with the lack thereof of medical records, or just the lack of the knowledge of what the prior history is for that particular patient. So, for instance, we get a patient in the clinic with a new referral from maybe 400 or 500 miles away in a remote area, and they make the travel to Houston to be seen, and you don't have the key important medical records. Then there is the challenge that comes in with insurance, and they will not approve for cross-sectional images, so until you have some sort of data. So I think from my role as a nurse practitioner provider, I think it's important to put it out there that as a congenital heart disease patient, it is very, very vital that you have some degree of data with you as far as what is your medical history, what is your surgical history, and you bring it with you and let that be a part of like your personal items like a cell phone or something you carry with you. If not, have it accessible in your email where you can remotely access certain important information for you to be seen, whether it's emergently, establishing care, or transferring care. And also for other providers, it's key and very important to share this information and ensure that the patient is progressed across care lines with adequate data so that we can continue to take care of these patients in a safe manner and a timely manner.
I think from a nursing standpoint, the two things that I really have seen as great challenges since starting in adult congenital, number one being the transition of care between the pediatric and the adult world. We have patients that come for a cath and can't have moderate sedation because every cath that they've had as a pediatric patient, they have, they say, I wasn't awake. I don't want to be awake. We've had patients that have actually, the day of their cath, turned around and gone back home. So I think that, in addition to also some patients come to us and they've had a gap in care, or they've said, or their parents have shared with us that, well, I was told I was fixed. Mm-hmm. And really just kind of changing that language to you are palliated, you're repaired, but you're never fixed. I think that has been a kind of a message that we're trying to send to each of our patients along the way. And probably the second, which I think has been my biggest challenge more recently, is other physicians outside of congenital cardiology really realizing that they do need to have a certain level of education or at least awareness of congenital heart defects, congenital patients, whether it be somebody that has a general cardiologist that says, oh, well, this patient's fixed, I can manage it. And there are certain things in congenital cardiology that are just out of that physician's realm. Or whether it be a primary care physician that just doesn't understand what that anomaly is and doesn't really tend to seek out the information. But I think that we've been able to kind of turn that corner with certainly symposia like this, but also just offering education. And that also applies to inpatient nursing, inpatient physicians, critical care physicians. We're trying to really kind of make that turn and really make them aware that our patients are going to be taken care of everywhere. They're going to be taken care of by every specialty. So every specialty really needs to have at least a little bit of knowledge or a resource of who they can contact that can provide the knowledge that they don't have and fill that gap. Because at the end of the day, that just is better for our patients. If we can take care of patients together and really provide that knowledge, then that is going to benefit our patients in the end.
Geez, everything I do is challenging, and it's because I'm sort of a consultant service. Probably my biggest challenge providing anesthesia for adult congenital patients is having other people recognize that, you know, your patient isn't just coming in for an EGD or a tooth extraction. You know, they have Eisenmengers, and you probably can't do that in the dental office or in the ambulatory setting. And then, you know, being engaged in the pre-surgical planning. Any patient coming for cardiac surgery in the cardiac OR, for the most part, tends to have a better workup. We know about it ahead of time. It's in the cardiac setting. But, you know, patients coming for GYN surgery that show up in the outpatient clinic but have a congenital diagnosis that nobody planned ahead for, that we need to bring over to the cardiac OR to have it safely done. So I guess my biggest, not issue, but my biggest challenge is in the care coordination, the pre-planning. People are very comfortable with things. In the anesthesia world, people are very comfortable taking care of patients until they aren't comfortable taking care of that patient. which is to say, you don't want people to go down the rabbit hole. You know, you want pre-planning. You want it to be referred to the appropriate operating room. Like you had mentioned before, you don't want to be delivering in a small rural midwifery center or delivering at home when there are plenty of resources to, you know, particularly guide advanced congenital patients through pregnancy, guide advanced congenital patients or complex congenital patients through what might not be a big surgery, but there's other issues that we need to address and take care of. So.
So I have that unique perspective because I am a congenital heart patient, but I've also been the role of the nurse who's trying to educate the families about their child's congenital heart disease. As a patient, my biggest challenge is your non-cardiologist specialist, if that makes sense. Anybody who does not work in, no congenital heart disease, they see your diagnosis, and I've literally had an OB say, all right, summarize your heart defect in 2 sentences. And it's difficult to. Imagine if I didn't have my background as a nurse to come up with, okay, this is my heart defect. And then being in a very small, remote area, I mean, we're a town of 40,000. It's where do I go to get care if something were to happen? That terrifies me. But I live where I live, and I have to trust that if I call the right people, hopefully I can get out of there and get to the right location. So finding people that are willing to take care of you, that don't want to be, I don't want the doctor to be someone who's like, well, you're my first, so let's do this. I want them to be willing to go, I've never done this before, so let me give you to someone who has. That's kind of what my biggest barrier is just making sure that you have doctors who admit that. As a nurse is getting the patient to recognize their own diagnosis, getting to recognize that it's like they've all been saying, it's not something that they fixed. And it's easy to say, here, I'm standing right here as your nurse, and I still see my doctor. You can't ever stop. It's one of those, you're never fixed. It's lifelong.
Wow, I think we could do a show on each and every one of the answers that these people gave. They were so excellent. Okay, I put out there on Facebook today that we were doing this, and I asked if anyone had any questions. And so, Dr. Montero, I think you're going to be the one to answer the first question. I had a heart mom who contacted me and said her 22-year-old son was born with hypoplastic left heart syndrome. And her question is, what considerations or information should they stress to the team for her son's upcoming cardiac catheterization? Her son recently had non-cardiac surgery. He had a hole in his eardrum that he had to have repaired, and it took over 6 hours for him to come out of the anesthesia. He has a failing Fontan, cardiogenic liver. His SATs run 76 to 78, but when he's on oxygen, they run about 84 to 86. So they think that there's possibly a right ventricular failure happening right now, and his cath is scheduled for the end of the month.
So this is actually a pretty typical patient that we get for anesthesia in the adult congenital world. And they're very complex. So the metabolism of drugs, given the state of the liver, the state of the kidneys, is different from your normal 20-year-old patient. Your circulation times are different. There was a question on the board earlier that when we had the Fontan panel about mechanical ventilation. Granted, for a cardiac cath, you should be somewhat irregular to have mechanical ventilation, but for ENT surgery, it'd be very common. And the question I saw before when I was sitting in the back was something along the lines was mechanical ventilation in a Fontan, is it always a no-no? And sort of the traditional thought was, yeah, it's kind of a no-no. It's not an absolute no-no. Avoid it if possible, but don't seek out spontaneous ventilation so that the patient becomes hypoxic, hypercarbic, acidotic, the pulmonary vascular resistance changes. Patients with failing Fontans for anesthesia, everything needs to be titrated specifically to that patient. There's no set formula. For a cardiac cath, I'm assuming you can get away with light sedation. That's being said in the setting of no, I always call it along the spectrum of post-traumatic stress disorder from when they were a child, that they can tolerate a cath under sedation or under nothing. And that's not always true. Some patients, I remember one specific patient who saw my roll of medical tape and just freaked out. And that's not a patient that was going to tolerate any procedure without being asleep. The considerations that I would say when they pertain specifically in anesthesia would be to contact the team doing your anesthesia prior to showing up on the day of. I'm assuming it's going to be done at a center where people are comfortable with adult congenital. They're doing the congenital cath there. But the more heads up time you can give to your anesthesiologist, the more that they can schedule the appropriate provider to do the case. And like I said, there's a huge amount of variation. They may have somebody on staff that did a bunch of pediatric cardiac. They may have somebody that's an adult cardiac person who's comfortable specifically with single ventricle patients. In the anesthesia world, the more we know ahead of time, the better. There's nothing worse than traveling a long distance and not having the adequate resources there and having to be rescheduled. That's the absolute worst. It's time off from school, it's time off from work, it's a lot of added stress. So I would really say contact the facility where you're gonna have it done, ask to speak to anesthesia. The parlance to use is, can I talk to the anesthesia board runner? That's sort of the person who runs the day-to-day for anesthesia. There's usually somebody in that position. And explain your situation, say when you're coming in, who your cardiologist is, and that you're gonna be showing up for a cath, you have a single ventricle, these are your additional concerns. You had a very long emergence from anesthesia prior. These are all awesome pieces of information to discuss with your anesthesia provider ahead of time so that you can do the appropriate planning. And it's not just for the procedure, it's also for post-procedure monitoring. For anxiolysis before the procedure is always a big one. And then always to have an emergency plan. Nobody wants to be functioning in the emergency setting when it can all be controlled ahead of time. So I hope that helps.
Absolutely, that was excellent. We had another hypoplastic left heart syndrome adult who said she's wondering why she gets so tired even though she's only 31 years of age. She was born with hypoplastic left heart syndrome. She works all the time, she said, but she gets tired especially after she eats.
Me
So-
too. Me too.
Fatigue is a somewhat non-specific symptom, and I could come up with, probably 10 possibilities as to why she might be getting tired. We'd have to know kind of how long it's been going on, if anything has changed recently. I guess speaking in general terms, she has a more limited capacity to increase her cardiac output as compared to people with two ventricles. And as a result, when she's engaging in an activity that demands an increase in cardiac output, including walking around in the store, going shopping, or even eating, requires some degree of augmented cardiac output to increase blood flow to the gut. That may result in symptoms of fatigue, in particular if she's kind of riding the edge of limitation in cardiac output at baseline. So her fatigue, which may be nothing more than a symptom that she's progressing towards the stage where she's not able to do the things that she would like to be able to do with her current circulation, and that she needs to start to consider more advanced options. And I know that Laith spoke about this yesterday, but I think I'm a big proponent of the same idea, that making certain that you're, as a patient, followed closely and carefully, and that when you develop signs or symptoms of heart failure, including what this woman may be experiencing, that you get referred for possible advanced care earlier rather than later, because people who are 23 years old have a lot of physiologic reserve. But in her case, unfortunately, I can't tell. I mean, maybe she's not sleeping well at night. Too much YouTube, or.
Well, yeah, I would be concerned. At 31 years old, she probably has a classic.
31.
Yeah, 31. She probably has a classic
23,
Fontan, and you wonder, okay, is this the case where maybe they need to do some of that amazing imaging that we learned about earlier tonight to see exactly what's going on? Yeah, excellent. Okay, I have one more question because we're almost out of time already. And I had an adult, Carl Walford, who wrote in and said he's wondering, regarding congenital heart defect community support, are adults living with congenital heart disease, aside from social media, are they able to get support from the medical community where they're actually being matched with other adults who might have the same experiences they do? Go, Joe.
There is the Adult Congenital Heart Association has the peer-to-peer support groups, and will do some matching, although I don't know if it's how well they're matching with your specific disease or condition, and also. I also do some of that, peer-to-peer support as well, and I have two other advocates that work with me. There's some resources out there for that kind of stuff, but as far as like matching, as well as you can match, it's one problem with this group is it's pretty heterogeneous group, so to match is kind of a hard thing to do. So, but yeah, he could totally reach out to me, Team Uncle Joe, or the ACHA peer-to-peer group, or used to be the ambassador group, could match as well. Or Mended Little Hearts also has their network as well, but that's typically more for the parents. Was he a patient?
He's older. He's in his 50s or 60s, I want to say.
Okay.
So
Yeah.
I think it's hard to find other people who are like him who share his experience. So he was wondering where he can reach out aside from social media. And I also know that Kids with Heart is a national organization that does do some parent matching, like you said, Joe. I think it's more common to have parent matching than it is matches for adults with congenital heart disease.
Yeah, for sure. And like was mentioned before, the 60-year-olds that are living, I think we see a lot. The 60 and 80-year-old tetralogy patients that appear on social media and tell the parents that your kid's going to be fine. That's 1 year old and already had 3 open heart surgeries. It's a different spectrum, and every year the spectrum is getting shifted to the more severe cases surviving. So it's a constantly shifting towards the more severe cases surviving. So his experience as a 60-year-old is going to be totally different than even my experience as at 37. So trying to find somebody in his age group would be the best for him.
Right. Well, I want to thank all of the panelists and Dr. Huie Lin for inviting me to do this live show here at Methodist Hospital. I want to also thank all of the sponsors of the conference and, of course, Methodist Hospital itself. And I want to thank everybody who sent in their questions. And remember, my friends, you are not alone.
Anna. So this is usually our favorite part of the event, where we get to go upstairs to the Mighty Lab and actually do some hands-on work. So what we're going to do is we're going to split everybody up into 3 different groups. If you don't necessarily feel comfortable doing hands-on learning, you do have an opportunity to do some other learning upstairs as well. But either way, we're all going to head up to the 5th floor now. Faculty as well, you're going to have your assignments set up as you go upstairs. It'll be based upon your teaching groups this morning. So we'll see you guys upstairs.
This is about lighting the match, creating the fire, basically, of interest and innovation. It's a meeting of the curious. This is a platform by which we can get together and we can actually share these ideas and share these concepts. And the solution really is the other guy's toolkit, making your knowledge transfer between industries. And those hills today are in petroleum industry, aerospace, and in medicine. This is called pumps and pipes.
This is not like your typical anatomy class from medical school. This is more goal-directed anatomy, so you know exactly what surgeries you're going to have, you know exactly what exposures you're going to be expected to know. So you go into the cadaver lab knowing exactly what you want to achieve, what you want to accomplish, and you go right straight for it.
Experiences such as this are very valuable because they make you a better technical surgeon, with people actually explaining what I'm looking at and how to get to that vessel or how to expose that portion of the aorta and what to put, even in terms of retraction, how to retract things, simple things that make a huge difference, I think, when you're doing a 6-hour operation.
Having kind of time to take a step back from the chaos of the operating room and really tease out the finer points of safe open aortic surgery. And have an environment to kind of ask questions in a non-punitive way has been very, very fruitful for me.
The average vascular surgery resident or fellow in the United States finishes with only 5 open aortic aneurysm repairs during their training course. And so one of the gaps in training these days has been the switch from open to endovascular surgery. And so those patients that do still require an open operation, we're now asking the youngest surgeons with the least experience to do those toughest operations.
In the OR, when you're, scrubbed in, people don't necessarily always verbalize what they're thinking or what's the correct technique. And I mean, this is amazing that we have such great vascular surgeons here that are willing to take the time to actually go over these technical aspects.
Of course, having Dr. Ide and Dr. Lumsden available, but also having group mates, your peers and people that you've seen along the way in the interview trail for vascular surgery. And then to be able to, again, interact with them and participate on the dissection, for example, and having a chance to learn from each other and cross-pollinate.
There are 0 reasons for you not to come. I think thinking if you already know your anatomy and you already know your exposures, coming here you refine these skills, and a lot of the tips and tricks that you may not get from your attending in the OR, Dr. Ite and Dr. Lumsden just grant them to you.
In our field of vascular surgery, with endovascular approaches becoming much more mainstream, open aortic surgery tends to kind of fall to the wayside. And I think in the grand scheme of providing the most effective and safe patient care, open aortic surgery is something that we need to have a mastery of.
Hello, I'm Dr. Faisal Masood, and I'm the Medical Director of Critical Care at Houston Methodist Hospital. I'd like to invite you to join us in Houston for the annual Critical Care Symposium. This special event will be held at Houston Methodist Research Institute in the Texas Medical Center. This one-day symposium is designed for the interprofessional critical care team. As such, you will hear diverse lectures from experts representing a wide variety of critical care topics. Then, after a morning of didactics, you will practice your new skills in expert-led hands-on workshops or breakout sessions. You will leave Houston Methodist with the confidence to apply these skills in your everyday ICU practice. For further details, visit the website. Caring for critical care patients is a team effort. So we have created this conference for the entire critical care team. So if you work or train in the ICU, this course is for you. I hope you will join us and look forward to seeing you in Houston in January. Thank you.
Heart of a Woman is such a unique event because it's open to not just the public, but also healthcare providers. So the audience is a mix of all different learners. I think the speakers are also a mix. So you not only get to hear from the cardiologists, but you also get to hear from the mayor, and you get to hear from chefs and dietitians and different people who are experts in their field. So you really get a well-rounded message about how to take care of yourself so you don't develop heart disease.
I decided to dedicate my Saturday to Heart of a Woman because it's a one-time-a-year event. And that's relevant because there is no other place in Houston, no other day of the year where I can hear this many experts on women's heart health.
Heart of a Woman is an important meeting. It's our second annual Heart of a Woman conference. The reason it's important is because 1 out of 2 women in this country are going to be affected or are affected by heart disease. Yet only 1 in 5 women even know that heart disease is a problem for women. So we're trying to get the word out. We want women to know about heart disease.
Heart disease is one of the leading causes of death in the city of Houston. And I think we're all trying to find a positive path forward that will reduce the number of women who are dying because of heart disease, and to help to live better, high-quality lives. City of Houston wants to partner with the Methodist Research Institute and with others to achieve those objectives.
I truly, authentically care about women's heart health because I'm a woman, but I would be remiss if I didn't talk about how wonderful it was to be with over 100 women that we all, for today at least, share the same purpose to try to learn more about heart health and share with other people that we love.
Unlike many of the very acute diseases where it may be more surgical, heart failure is a chronic disease and it's a team sport. Everybody's involved, the patients, doctors, nurses, pharmacists, physical therapists, and it's really a multidisciplinary team. It is one thing to go to talks by theoreticians, but here this is a large volume center, a lot of patients, advanced heart failure, transplant, VAD, everything. So many of the speakers are day in, day out taking care of their patients. So there is also a practical side of how to do things which does not come with just reading the papers. So you will get latest knowledge, but also latest knowledge from people who are doing this day in and day out.
I've recognized since I've been here that Houston is a mecca and has some very talented people working on some pretty important things here. As a nurse practitioner, it's important to me to be able to come to a conference that helps build my understanding of what's happening for the patients, so that then I can translate that to their care at the bedside.
The importance of this conference, and I think the uniqueness of it, is bringing people from different facets of imaging to talk about, one, what is the latest, two, how do we apply it in clinical medicine, and three, how can we be better clinicians in serving our patients, learning about all these imaging modalities.
The beauty of this conference is that it looks at the role that imaging, all techniques of imaging, have in the diagnosis and management of heart disease. And I think that's absolutely critical today, because imaging of the heart is really the gateway to diagnosis and management. This gives you a chance to look at the breadth of these imaging modalities, learn about something you don't know about, get a better appreciation of it, and really understand how all the integration of these imaging is going to make a major difference in the future.
Every time you come, you learn a little bit more. You get familiarized with the scans, you get familiarized with what's the latest out there, and you have to constantly be adapting to change, because, you know, we have to stay up to date with the latest inventions, the latest scans, the latest protocols that will better help the patient.
Okay, so I'm Anna Jaworski, and I'm here with Zachary Perkins. Hi, Zachary. Can you tell us about the devices that you have here?
Yes, I'm Zachary Perkins with Bayless Medical. So right here what we have is EP and IC, so electrophysiology and intrastructural cardiology devices. Now this is focused strictly on going transeptal. Okay, so that's going from one part of the septum over to the next. So we're going from the right atrium to the left atrium. Now we'll start off with we have cross. We'll go through the jugular vein, and that's going to allow us to go to the left side of the heart. Now, the specific piece of this that makes it really safe is the RF wire. RF wire of using mechanical across the septum. Traditionally we use taking a sharp needle, poke across. What we do, we only have to use RF energy to zap across for 2 seconds. So using that minimum amount of RF energy, that makes it a lot safer and gives you a good placement on the septum, so you can give your left-sided therapies, you know, whatever you may want to do.
Wow, that's amazing. So it probably really reduces the opportunities for there to be a problem, a puncture, or any kind of accident, right?
Yes. So when transeptal, a big part of it we never want to puncture, because that instantly, you have to instantly go to the OR. You have to open someone up, and that's very invasive. We don't want to do that at all. So with this gives us time and safety to find our place on the septum, exactly where we want to go. So we can look on imaging. We can look, see how close we're from the aorta, posterior, anterior, see how high and low we are on the septum. And by doing this, our main device here is our energy needle. So it's a blunt end as opposed to a sharp end like a needle. So it has 2 side ports, which you can do the exact same thing if it was open lumen. But you're able to drag it across the septum without actually shavings off the septum.
Wow, that's amazing. Can I feel that? Oh yeah, that really isn't that sharp. I mean, it looks sharp, but it's really not that sharp.
It's not. And that really helps, especially with fellows learning how to go transeptal. It really helps them, gives them time and safety to find the right exact area they want to go transeptal.
And then what about this?
So right here we have our expansor. So normally we have a sheath and dilator. So once we use that workflow, we would pull the dilator out, we'd advance the catheter, ablation catheter, or a Watchman catheter, whatever left side there we're doing, therapy we're doing. But this is all in one. So what we use here is all in one, so it saves us steps in procedure time. So less chance for complications, more time to get the actual therapy. So we're focusing strictly on minimizing procedure time and minimizing any contraindications like for safety precautions.
Wow. Well, this looks amazing. Thank you so much for talking with me
Thank you so
today.
much. It was nice meeting you.
Nice to meet you. Wow. Okay.
How you doing?
Let me know. Okay.
Okay.
So tell me your name again, James.
James Raz.
James Raz. Okay.
Penumbra.
Okay.
What I have here is just our neural model to where kind of.
We're not live yet. Okay. So I'm here now with James from Penumbra, and he is going to tell us about the devices that he has here at the conference.
All right. So what I have here is just a microcatheter going into an aneurysm that's in the vertebral artery. But it's just to kind of show you guys what the doctors do whenever they use coils in an aneurysm. When they coil an aneurysm, they get a microcatheter up to the area, and once they have the catheter there, they'll just kind of push forward these coils. And as you can see there, at the very tip right there, you can see it that it starts to kind of fill in that vessel. So this can be done for aneurysm or any vessels that the doctors want to stop the flow to. Let's say, for example, for GI bleed or some preoperative embolizations that they want to do, they can throw in these coils, stop the flow to the organ, and then they can resect that organ or that area that they need to.
So I have a lot of friends whose children have had to have coils. I didn't know it started as a straight piece of wire and then it became coil. That's
Yes,
fascinating.
So it is just one be just this is like if you want to touch it, it's like just nice and super soft.
Oh, it is super
But,
soft.
Our coils have no fibers in them, so it creates but it's soft enough that it creates a mechanical dam. So there's no blood flow that's going through. Coils will have those fibers, and they rely on the patient's blood to actually start to clot up in those fibers to stop the flow. So when patients are have really thin blood and they can't clot, our coils have a little benefit for those patients. And it's a mechanical detachment of these coils. Just a little ball drops as soon as they pull the little tubing, so the coil stays in place where the doctor places it.
That is fascinating, yes.
So the way the detachment is the coil is attached to the pusher, and there's a little wire. Once the coil is detached, and you pull the trigger, the little wire is pulled back and the ball so when the doctor pulls this pusher out, it stays in place.
And you can actually see the coils in place right here.
Take me through this. So what we have here is doctor gains access. I'll go ahead and pull back the coil for a moment. The doctor gains access to the vessel with a microcatheter. Let's say he got into that vessel there that he wants to embolize and throw some coils in. This is your subclavian going into the vert, and then from the left vert goes into a basilar tip aneurysm. So the coil gets pushed out by the doctor, and you can see it fill in, and it's kind of painting that aneurysm. Is designed to take 540 turns. It comes out as 540, then 450, 540, kind of spinning around to create a complex shape just like that, to fill up majority of the coil, the aneurysm. So the walls are protected, so there's less chances of the patient.
And how does the doctor know when to stop? When there's enough coil in there?
So he'll, in between coils, he'll do an angiogram and see the actual flow of contrast, and then he can assess how much contrast is going into the aneurysm.
Wow, that's just fascinating. Thank you so much for explaining that to us. This is fabulous.
then go in with this stent.
Yeah, that's what I
Great question.
that's what I was
So,
going to
yeah,
ask.
great question.
This is about lighting the match, creating the fire, basically, of interest and innovation. It's a meeting of the curious. This is a platform by which we can get together and we can actually share these ideas and share these concepts. And the solution really is the other guy's toolkit, making your knowledge transfer between industries. And those hills today are in petroleum industry, aerospace, and in medicine. This is called pumps and pipes.
It's called rotational atherectomy. Now let me show you something else cool. So this net.
This is not like your typical anatomy class from medical school. This is more goal-directed anatomy, so you know exactly what surgeries you're going to have, you know exactly what exposures you're going to be expected to know. So you go into the cadaver lab knowing exactly what you want to achieve, what you want to accomplish, and you go right straight for it.
Experiences such as this are very valuable because they make you a better technical surgeon with people actually explaining what I'm looking at and how to get to that vessel or how to expose that portion of the aorta and what to put, you know, even in terms of retraction, how to retract things, simple things that make a huge difference, I think, when you're doing a 6-hour operation.
Having kind of time to take a step back from the chaos of the operating room and really tease out the finer points of safe open aortic surgery. And have an environment to kind of ask questions in a non-punitive way has been very, very fruitful for me.
The average vascular surgery resident or fellow in the United States finishes with only 5 open aortic aneurysm repairs during their training course. And so one of the gaps in training these days has been the switch from open to endovascular surgery. And so those patients that do still require an open operation, we're now asking the youngest surgeons with the least experience to do those toughest operations.
In the OR, when you're, you know, scrubbed in, people don't necessarily always verbalize what they're thinking or what's the correct technique. And I mean, this is amazing that we have such great vascular surgeons here that are willing to take the time to actually go over these technical aspects.
Of course, having Dr. Ide and Dr. Lumsden available, but also having group mates, your peers and people that you've seen along the way in the interview trail for vascular surgery. And then to be able to, again, interact with them and participate on the dissection, for example, and having a chance to learn from each other and cross-pollinate.
There are 0 reasons for you not to come. I think thinking if you already know your anatomy and you already know your exposures, coming here you refine these skills, and a lot of the tips and tricks that you may not get from your attending in the OR, Dr. Ite and Dr. Lumsden just grant them to you.
In our field of vascular surgery, with endovascular approaches becoming much more mainstream, open aortic surgery tends to kind of fall to the wayside. And I think in the grand scheme of providing the most effective and safe patient care, open aortic surgery is something that we need to have a mastery of.
Scientific, and I am excited to learn about some of the different equipment that you have here at Methodist.
Thank you very much. I work for the Interventional Cardiology Division of Boston Scientific. There are many different divisions of Boston Scientific, but I'm more of the plumbing side. So anytime someone has coronary artery disease, we have a number of devices that can address coronary artery disease. We have everything for access. patient, as well as the devices they actually implant into the patient. For example, coronary stents. Would you like to see one?
Yes. Yes, that would be great.
Here is a coronary stent that is made out of platinum chromium. They're very, very tightly mounted on a balloon catheter. Then we take this into the coronary artery and we use an inflation device. We inflate this balloon that's underneath this stent. The stent is expanded and then the balloon is removed. And so there's medication on this stent that will kind of bathe the artery to help promote picking up again. So fantastic technology for a physician to be able to use for a patient that has disease. We also have devices called intravascular ultrasound. We have a device called rotational atherectomy, which this is a little burr that has diamonds on the end of it. And it is basically a high-speed rotary sander that sands away the plaque in the arteries. We have, I think I said we have intravascular ultrasound that we can actually go in and take a look at the coronary arteries to look at the morphology of the plaque. And then if a patient has had bypass surgery, we have these little filters that we can go in and use these filters to capture. There's no debris going down when working on vein grafts for patients. We also use filters in the carotid arteries when patients get carotid stenting. So there's a number of different types of filters that are available. We have a huge gamut of products for artery disease as well as coronary artery disease, but I'm just focusing here today on the coronaries.
So how common is it for adults who are born with congenital heart defects to also have coronary artery disease?
So I don't know exactly what the percentage is, but oftentimes patients as they get older will have different needs. They may need a pacemaker of some sort, or they may need to have a stent implanted into their artery. So, but it does happen, and that's why Dr. Lynn had invited us to come so that the patients can really understand the procedure and what's going to happen to them in the cath lab, and also what type of devices are available to them.
I think what is amazing, my son is 25 years old, and 25 years ago they were not giving us very good prognosis, but now we're seeing so many adults who are living way beyond. Seeing people who are in their 30s and 40s and 50s, so then they're going to get the same acquired heart disease that anybody, even if they were born with a healthy heart, might get. So it is really helpful for them to know about this.
The field of coronary, just cardiology in general, is incredible. I wish I were 20 years younger, because even now what's happening, I think I heard a physician say this morning that we might think that what we're doing now is, delusional in 20 years. But we really have amazing tools for the coronaries, and Methodist Hospital is equipped with all of these devices, and if a patient needs quality care, they should come here to get their care because they have everything they need.
And a lot of what they need apparently is with Boston Scientific. You guys are one of the leaders.
Yeah, we are. There are a lot of good companies out there that have a lot of really good devices, but I'm very fortunate to work for a company that is really focused on innovation and taking care of patients.
Well, thank you so much. I appreciate it. This was fascinating. I can't believe there are diamonds on the end of this.
Diamonds on the end. If they were really worth anything, I would probably make earrings out of those, but they're not.
They're valued not in
for saving lives. Absolutely. Here's another little device that I didn't show you, but this is a cutting balloon, and
awesome.
Well, and you can
Okay.
see our patient over here is very happily sedated.
Oh.
So we have a very happily sedated patient.
Yes.
And, you know, if they come here, they're very happy.
Absolutely.
Yeah,
Absolutely.
yeah.
And they should be. Technology that
thank
can
you.
save their lives.
Well, it's, I mean, it really is incredible. If you've got, I mean, really anything going on in the heart, I would so much rather have an issue with my heart than another body part, given the fact that the knowledge that I have of the tools that are available to be able to take care of that.
And 26 years of experience, you know what you're talking about.
I hope so. I bet.
Thank
Thank
you,
you,
Thank you
Anna.
so
I
much.
appreciate it. Bye-bye.
Okay.
Hello, I'm Dr. Faisal Masood, and I'm the Medical Director of Critical Care at Houston Methodist Hospital. I'd like to invite you to join us in Houston for the annual Critical Care Symposium. This special event will be held at Houston Methodist Research Institute in the Texas Medical Center. This one-day symposium is designed for the interprofessional critical care team. As such, you will hear diverse lectures from experts representing a wide variety of critical care topics. Then, after a morning of didactics, you will practice your new skills in expert-led hands-on workshops or breakout sessions. You will leave Houston Methodist with the confidence to apply these skills in your everyday ICU practice. For further details, visit the website. Caring for critical care patients is a team effort. So we have created this conference for the entire critical care team. So if you work or train in the ICU, this course is for you. I hope you will join us and look forward to seeing you in Houston in January. Thank you.
Heart of a Woman is such a unique event because it's open to not just the public, but also healthcare providers. So the audience is a mix of all different learners. I think the speakers are also a mix. So you not only get to hear from the cardiologists, but you also get to hear from the mayor, and you get to hear from chefs and dietitians and different people who are experts in their field. So you really get a well-rounded message about how to take care of yourself so you don't develop heart disease.
I decided to dedicate my Saturday to Heart of a Woman because it's a one-time-a-year event. And that's relevant because there is no other place in Houston, no other day of the year where I can hear this many experts on women's heart health.
Heart of a Woman is an important meeting. It's our second annual Heart of a Woman conference. The reason it's important is because 1 out of 2 women in this country are going to be affected or are affected by heart disease. Yet only 1 in 5 women even know that heart disease is a problem for women. So we're trying to get the word out. We want women to know about heart disease.
Heart disease is one of the leading causes of death in the city of Houston. And I think we're all trying to find a positive path forward that will reduce the number of women who are dying because of heart disease and to help to live better, high-quality lives. You know, City of Houston wants to partner with the Methodist Research Institute and with others to achieve those objectives.
I truly, authentically care about women's heart health because I'm a woman, but I would be remiss if I didn't talk about how wonderful it was to be with over 100 women that we all, for today at least, share the same purpose to try to learn more about heart health and share with other people that we love.
Unlike many of the very acute diseases where it may be more surgical, heart failure is a chronic disease and it's a team sport. Everybody's involved, the patients, doctors, nurses, pharmacists, physical therapists, and it's really a multidisciplinary team. It is one thing to go to talks by theoreticians, but here this is a large volume center, a lot of patients, advanced heart failure, transplant, VAD, everything. So many of the speakers are day in, day out taking care of their patients. So there is also a practical side of how to do things which does not come with just reading the papers. So you will get latest knowledge, but also latest knowledge from people who are doing this day in and day out.
I've recognized since I've been here that Houston is a mecca and has some very talented people working on some pretty important things here. As a nurse practitioner, it's important to me to be able to come to a conference that helps build my understanding of what's happening for the patients so that then I can translate that to their care at the bedside.
The importance of this conference, and I think the uniqueness of it, is bringing people from different facets of imaging to talk about, one, what is the latest, two, how do we apply it in clinical medicine, and three, how can we be better clinicians and serving our patients, learning about all these imaging modalities.
The beauty of this conference is that it looks at the role that imaging, all techniques of imaging, have in the diagnosis and management of heart disease. And I think that's absolutely critical today because imaging of the heart is really the gateway to diagnosis and management. This gives you a chance to look at the breadth of these imaging modalities, learn about something you don't know about, get a better appreciation of it, and really understand how all the integration of these imaging is going to make a major difference in the future.
Every time you come, you learn a little bit more. You get familiarized with the scans, you get familiarized with what's the latest out there, and you have to constantly be adapting to change because, you know, we have to stay up to date with the latest inventions, the latest scans, the latest protocols
and she's
that will
going
better
to tell
help
us
the patient.
about this amazing imaging device.
Hi. So we are an advanced medical imaging software. So we take any kind of diagram, ultrasound, MR, CTs, and turn it into an interactive virtual reality form. So what you're looking here is not a simulation, not a model, it's real patient data.
Okay, and you told me before when I worked with you that it's actually tuned into the glasses that I am wearing.
Yes, so we have two types of glasses. The ones you are wearing are what we call driving glasses. So it's being tracked by the system. Here you see these red dots. And so when you move, the data moves with you, so it's not going to give you like this real world. And the glasses I'm wearing are like passive glasses, so I'm seeing everything in 3D too, but in your perspective, basically. You are.
So you're seeing what I'm seeing.
Right.
So can you show us how this image actually can move?
Sure. So we are using this stylus, and I'm holding like a pen, and once I interact with the image, like you see this ray goes blue to green, and I press this front button and I keep it pressed. So instead of looking at this CT image, the physicians are looking at this image, and you can see the anatomy much clearer in a much real world way. And depending on your interest, We have different filters or transfer functions, what we call more technically. And you can highlight different tissues and structures in the image and discuss with your surgical team or operational team or diagnostic team, whatever you are talking about the case, basically.
So, what doctors would be using this device?
So in here, adult congenital heart disease, very, very much so. Pediatric cardiology, adult cardiology, surgeons, pretty much anyone, any physician who are interested in using and getting a more real life image of the working on.
Is this the kind of device that they would use to help plan a surgery?
Yes, it's a surgical planning software, but people are also using it for diagnostics and in cath lab, and also post-operative, like controls, checks once they implant their devices to make sure that it's in the right place. Because, for example, in this image, you can see the endoluminal, the internal structures pretty well. So if a device is implanted here, you can see if it's fitted pretty nicely. So in multiple stages of the patient care. And believe it or not, some people use it for patient engagement too.
I was just going to ask, is this the kind of device where the surgeon and the team could sit down with the patient and say, okay, here's what to do?
Any positive feedback from the patients because they were like, oh, it's the first time I'm really understanding what's going on in my heart. And yeah, I see a couple of surgeons actually sit down with their patients and describing and putting a virtual device and explaining, and yeah.
Yeah, because what's nice about this is that you're actually looking at your heart. You're not looking at a model, but they can actually with your own heart what the structure of the heart is and how they're going to have to manipulate the devices inside of your heart to do whatever procedure they need to do. So, right?
Right. That's correct.
Wow, this is just amazing. Now, is this something where they have to go to a special lab to use it, or is it in the doctor's offices?
So it depends where where the hospital wants to place it. So some physicians would like to put there in their office. Some people like to put it in the surgical area. Some hospitals have two systems. They put one in doctor's cardiologist office, one is the surgery work between. So it really depends on what the physicians would like to do with the system, and we are supporting it. Like as the company, we are pretty flexible in their use cases.
So how do they get the images onto the screen like that?
So what generally the physicians store their images in a network, in a server, like PAC system. So what we do is we remotely connect our software to the server, and remotely basically any other.
So it's actually almost instantaneous that they can have that imaging taken from wherever it is that they store it and put on here so that they can either conference with professionals or conference with their patients.
Right. Yes.
Wow, that's really handy. This is just amazing. And I can't believe, I feel like it's almost a science fiction type thing. Here I am with 3D glasses looking at this, and it would give me a much better idea of what needs to be done if they were working on my heart.
Yes, so that's our hope. Like that's what we want to help the physicians to.
Isn't it hard to believe, 30 years ago, doctors almost went in blind, or they would just discover as they had the patients open on the table exactly what they would be focusing on. And now they can use something like this. They're so much better prepared. I would imagine that with the imaging service like this or an imaging device like this, there would be so much fewer problems, accidents, and that their surgeries could go faster and more efficiently.
Yeah, that's the hope. We need to do more research and everything about it, but that's our aim, and that's what we would like to do.
Thank you so much for talking to me about this. This is really amazing.
Yes, thank you so much. Thank you for your interest.
The importance of this conference, and I think the uniqueness of it, is bringing people from different facets of imaging to talk about, one, what is the latest, two, how do we apply it in clinical medicine, and three, how can we be better clinicians and serving our patients, learning about all these imaging modalities.
The beauty of this conference is that it looks at the role that imaging, all techniques of imaging, have in the diagnosis and management of heart disease. And I think that's absolutely critical today, because imaging of the heart is really the gateway to diagnosis and management. This gives you a chance to look at the breadth of these imaging modalities, learn about something you don't know about, get a better appreciation of it, and really understand how all the integration of these imaging is going to make a major difference in the future.
Every time you come, you learn a little bit more. You get familiarized with the scans, you get familiarized with what's the latest out there, and you have to constantly be adapting to change, because, you know, we have to stay up to date with the latest inventions, the latest scans, the latest protocols that will better help the patient.
This is all about community, and having this dialogue is really very, very key to understand that somebody else is going through a similar type of problem. But when you find out that the person next to me has the same problem, the person across has the same problem, it gives you some solace that you're able to get through these very tough times when there's a community and you have other people to reach out to.
This conference is great, and I enjoy coming here. It helps me with encouragement. It's also to have hope, and to provide hope to others. Because sometimes we can get a little down, or, you know, it's dealing with this over and day after day after day, and I kind of need to hear that message more often.
In today's world, to get information on the condition, especially for conditions like congestive heart failure, it's very easy to get lost in. This is one of a few kind of conferences where we are doing it for individuals who are affected by heart failure, not for medical professionals. So I think this gives an opportunity for us to break that barrier and let them come to the right source where we as health professionals can clarify all possible questions, and in fact sometimes learn together.
Revolution is a meeting that started 10 years ago. The goal over here was to teach people new techniques that they could use in cardiac surgery, specifically minimally invasive techniques. The meeting is geared towards physicians in practice, but also trainees that are doing their training in cardiothoracic surgery where they don't necessarily get exposed to minimally invasive techniques such as the kind that they need to use in practice.
As a early career trainee in cardiac surgery, going to this conference means a lot to me, to be able to be exposed to the entire realm of minimally invasive cardiac surgery, to be inspired by world-leading experts and all the new and upcoming technologies that are coming forth for our field, and to be able to be inspired to innovate and to learn these technologies so that I can one day apply these in my practice and to be able to keep our specialty surviving and thriving.
There is a significant increase in awareness that these are less invasive procedures that do have a significant benefit. And to be able to come and train in these if they don't already know how to do these or are not familiar with them is something that will certainly benefit their own practice in their local environments, but more importantly, it'll benefit their patients and allows them to be on the cutting edge of cardiac care. To be able to do these and get the hands-on experience at Revolution Conference is an excellent opportunity.
This is about lighting the match, creating the fire, basically, of interest and innovation. It's a meeting of the curious. This is about lighting the match, creating the fire, basically, of interest and innovation.
So I'm here with Athena Anda, and she is a sonographer. She's going to tell us about how they are able to make the measurements to places in the heart. These are PFOs.
Using ultrasound, echocardiogram, we have multiple views of the heart that can give an idea of where the hole in the heart is located, as well as possibly what device we can use if needed to do it interventionally in the cath lab. So we would start basically here to get an idea of the size of the heart. There's a few views. We use color as well as Doppler to get the flow across the defect of the heart. Possibly the best view that we use, patient's belly. So once we locate the defect, we use color. Let's see if I can get that lined up here. Color, which is a great tool for us to find where the defect is. We can also measure the size of the defect and how much blood flow is going across that defect.
Right, because if there's a big hole and there's a lot of blood that's going through that, that could cause problems, right?
Absolutely. It could cause dilation of the heart chambers as well as other complications. So this is one of the devices that we would use in the cath lab. It kind of plugs the heart on both sides to prevent that flow of the heart and makes the patient overall feel better.
Right. Is that a clamshell device? Is that...
This would either be a Gore device or an Amplants device. We have several sizes that we could use in the cath lab.
Right, and so when the cardiologist is doing interventional cardiology, how would they know what size to bring in?
Using intracardiac echo or ICE procedures, we would do a very good measurement as well as a CT overlay sometimes.
Can you show us on a computer how you would actually measure for the device?
Absolutely. So you would want to find the best possible view. This would be a 4-chamber view of the heart. And as you can see, there's some dropout here. So that lets me know this is where the defect is. So if I can actually freeze this. We have calipers that can measure. So the defect would be about 2.1 centimeters. And from there, they can determine possibly what size device to put into the heart.
This is just amazing, and all of this can be done in a cath lab, so you don't actually require an open heart procedure, right?
That's correct. Some patients can be closed in the cath lab. Depending on the size, they would need surgery.
So what seems to be the case with this one? Would this be one that could be done in a cath
to wear a small device. Here.
And are they using, you have something totally different? Of the different imaging that this tip have a 3. Okay, so normally they wouldn't need something that elaborate. They would just be able to use this that you have here. They would be able to measure it, and then they would go into the cath lab and actually introduce that into the person's body. Tell me about what kind of imaging you do during that procedure.
I use ultrasound, but the probe, instead of being this probe, is actually attached to a catheter device. So it's ran through the patient's groin or neck or arm, and the images are displayed on an ultrasound machine.
So you're in the operating room with the interventional cardiologist, and you're all working together?
That's correct.
Well, thank you so much, Athena, for explaining this to me. This is really amazing. And you were even saying that some of the images that you get come from the stomach.
Correct. That's correct.
Can you show us why you would need to do that?
In order to get an accurate size of the defect, we use multiple views. So we would use a view from the stomach or abdominal area. We would use a view that shows us all 4 chambers of the heart. And we also use a view that
This is about lighting the match, creating the fire, basically, of interest and innovation. It's a meeting of the curious. This is a platform by which we can get together and we can actually share these ideas and share these concepts. And the solution really is the other guy's toolkit, making your knowledge transfer between industries. And those hills today are in petroleum industry, aerospace, and in medicine. This is called pumps and pipes.
These guys are technologically brilliant too.
This is not like your typical anatomy class from medical school. This is more goal-directed anatomy, so you know exactly what surgeries you're going to have, you know exactly what exposures you're going to be expected to know. So you go into the cadaver lab knowing exactly what you want to achieve, what you want to accomplish, and you go right straight for it.
Experiences such as this are very valuable because they make you a better technical surgeon, with people actually explaining what I'm looking at and how to get to that vessel or how to expose that portion of the aorta and what to put, even in terms of retraction, how to retract things, simple things that make a huge difference, I think, when you're doing a 6-hour operation.
Having kind of time to take a step back from the chaos of the operating room and really tease out the finer points of safe open aortic surgery. And have an environment to kind of ask questions in a non-punitive way has been very, very fruitful for me.
The average vascular surgery resident or fellow in the United States finishes with only 5 open aortic aneurysm repairs during their training course. And so one of the gaps in training these days has been the switch from open to endovascular surgery. And so those patients that do still require an open operation, we're now asking the youngest surgeons with the least experience to do those toughest operations.
In the OR, when you're, scrubbed in, people don't necessarily always verbalize what they're thinking or what's the correct technique. And I mean, this is amazing that we have such great vascular surgeons here that are willing to take the time to actually go over these technical aspects.
Of course, having Dr. Ide and Dr. Lumsden available, but also having group mates, your peers and people that you've seen along the way in the interview trail for vascular surgery. And then to be able to, again, interact with them and participate on the dissection, for example, and having a chance to learn from each other and cross-pollinate.
There are 0 reasons for you not to come. I think thinking if you already know your anatomy and you already know your exposures, coming here you refine these skills. And a lot of the tips and tricks that you may not get from your attending in the OR, Dr. Ite and Dr. Lumsden just grant them to you.
In our field of vascular surgery, with endovascular approaches becoming much more mainstream, open aortic surgery tends to kind of fall to the wayside. And I think in the grand scheme of providing the most effective and safe patient care, open aortic surgery is something that we need to have a mastery of.
Hello, I'm Dr. Faisal Masood, and I'm the Medical Director of Critical Care at Houston Methodist Hospital. I'd like to invite you to join us in Houston for the annual Critical Care Symposium. This special event will be held at Houston Methodist Research Institute in the Texas Medical Center. This one-day symposium is designed for the interprofessional critical care team. As such, you will hear diverse lectures from experts representing a wide variety of critical care topics. Then, after a morning of didactics, you will practice your new skills in expert-led hands-on workshops or breakout sessions. You will leave Houston Methodist with the confidence to apply these skills in your everyday ICU practice. For further details, visit the website. Caring for critical care patients is a team effort. So we have created this conference for the entire critical care team. So if you work or train in the ICU, this course is for you. I hope you will join us and look forward to seeing you in Houston in January. Thank you.
Heart of a Woman is such a unique event because it's open to not just the public, but also healthcare providers. So the audience is a mix of all different learners. I think the speakers are also a mix. So you not only get to hear from the cardiologists, but you also get to hear from the mayor, and you get to hear from chefs and dietitians and different people who are experts in their field. So you really get a well-rounded message about how to take care of yourself so you don't develop heart disease.
I decided to dedicate my Saturday to Heart of a Woman because it's a one-time-a-year event. And that's relevant because there is no other place in Houston, no other day of the year where I can hear this many experts on women's heart health.
Heart of a Woman is an important meeting. It's our second annual Heart of a Woman conference. The reason it's important is because 1 out of 2 women in this country are going to be affected or are affected by heart disease. Yet only 1 in 5 women even know that heart disease is a problem for women. So we're trying to get the word out. We want women to know about heart disease.
Heart disease is one of the leading causes of death in the city of Houston. And I think we're all trying to find a positive path forward that will reduce the number of women who are dying because of heart disease, and to help to live better, high-quality lives. You know, City of Houston wants to partner with the Methodist Research Institute and with others to achieve those objectives.
I truly, authentically care about women's heart health because I'm a woman, but I would be remiss if I didn't talk about how wonderful it was to be with over 100 women that we all, for today at least, share the same purpose to try to learn more about heart health and share with other people that we love.
Unlike many of the very acute diseases where it may be more surgical, heart failure is a chronic disease and it's a team sport. Everybody is involved, the patients, doctors, nurses, pharmacists, physical therapists, and it's really a multidisciplinary team. It is one thing to go to talks by theoreticians, but here this is a large volume center, a lot of patients, advanced heart failure, transplant, VAD, everything. So many of the speakers are day in, day out taking care of their patients. So there is also a practical side of how to do things which does not come with just reading the papers. So you will get latest knowledge, but also latest knowledge from people who are doing this day in and day out.
I've recognized since I've been here that Houston is
We're explaining to everybody who can't be here what we're doing
important things
and why
here.
they should be here.
As a nurse practitioner, it's important to me to be able to come to a conference.
Who are all students, and their preceptor Damien, and they're going to tell us about Operation Heart.
Okay, so we're all pharmacy students at the University of Houston, and
just to educate of how salt content can actually increase your blood pressure.
And we'll be doing blood pressure screenings here today to screen for risk of hypertension, and important to do. These are high, so that's what we're doing here.
Well, thank you so much. It's really important for people who were born with heart defects not to get acquired heart disease on top of that, right? So thank you so much for sharing that with me. Okay, and now we're going across the way, and we're going to learn about symbionics. Hi. Hi, this is amazing. Okay.
You want me to start the whole thing over? So we're actually just showing off the Symbionics trainer, which we use for training our residents and fellows, and actually all of our staff too. So it has everything for vascular procedures, peripheral ones, as well as coronary. So that's what we're showing off right now. We've actually found a lovely lesion on the left side right now, and we were about to stent it. I was actually going to let them do it. So we've picked a JR4 catheter, just like we would do in the cath lab as well, to select that main coronary. And then now we were going to change our wire to a smaller one and actually run it across the lesion, so we could use the wire like a train track, actually, and then advance the stent over that wire in order to open up this problem space and restore blood flow to the lower edge of that cardiac muscle that is actually being starved right now because it doesn't have enough blood getting to it. So,
okay, so can you show us how we can do that?
Yeah, of course. So we're going to change our wire really quickly. And choose a smaller one. So we're going to choose a floppy 014 wire with a 30-degree tip on it. And then we're going to go up and advance the wire.
And you can actually see this on the screen if you're looking. You can see the wire advancing as she's moving it.
So now I'm trying to find the actual part of the vessel that my wire needs to go down, and we can see that I did the right one going down this side, and the wire's actually opening up the lesion. So now I'm going to advance the wire further down to almost get it stuck in the vessel at the bottom. So just like I said, to give us some traction, like a train track of sorts. So now we can advance another balloon over this catheter. So if we had enough catheters, we could do it. And so now we're just going to choose the right stent. We would have measured the proper stent lengthwise and widthwise to cover the proper lesion as well, but also not to just completely be too big for the space or too small for the space, because you could do damage both ways. So now we're going to show the stent going back up. And then you can see the two dots of the stent actually are the outline of the marker for where the balloon and the stent both are. So we use that as a reference point to cover our problem spot. So we can also do a little bit of injection of contrast and see that we're a little too far down. And now, as long as our lesion is centered in the middle of in between our two target dots, now we're ready to actually deploy the stent. So each stent we're usually going to go up to 12 atmospheres on this one. And there will be contrast as well in the balloon that we're going to inject. And the balloon, when it expands, is going to break apart whatever is there. In this instance, it's probably plaque, and it will open up the stent as well and kind of stick it into the walls of the artery per se and keep it open at this.
So when it breaks it open, do we have to worry about plaque getting into the bloodstream and possibly causing a stroke?
So in this particular sense, no, because if you're looking at the way the blood flow is actually going, you're going to force any sort of microparticles that could be released with us in breaking the stent are actually going to get forced downward rather than upwards towards the brain. What could happen if you were doing something in the carotids or another area where blood flow is actually directing it in a different direction. So at this point, particles that you're going to see are going to be very, 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 very small.
So since they're so small, will they be reabsorbed by the body instead of actually causing a clot?
Yes, usually they would, and it would also, we would have done CT imaging ahead of time. We would know the composition of this particular problem, you know, whether it's truly an old clot, a new clot, or if it's a clot at all versus plaque or some sort of problem that's in there. And so you would know the composition of it. If it was something that can't be opened or need to be opened, we'd need to remove that problem. It's the same way like a clogged drain. You can't just always force high pressure to open it up. Sometimes you got to pull all the leaves out. So if that's, you know, a thrombus, we would need to actually remove the thrombus from that area.
So if you're in there with the wire and you realize you can't poke it with the wire, then what does the doctor do?
So they can there's several. If you can't wire, there's an option to change the, because this one that we chose has actually got it's called a super floppy. So it's actually a very, very, very loose. It has no real support behind it. So it's almost like you're pushing up against something that you can't get through. You might change the wire, so you could change the wire to a stiffer wire, at which point that could give you more support. And also notice that maybe we need to slowly start to distend the vessel and also work with the balloon and the wire at the same time. And that's, you know, what cardiologists and interventionalists are very specialized at, is, you know, working those small micro movements in order to get through that. And now if we recognize there is just no way we're going to get through this, then this type of you know, minimally invasive access might not be the option that we end up going with. The way we can get through this is feasible anymore. There could be damage. We're also looking at all the hemodynamics at the same time. We might be causing more problems by having wires or devices in and around the heart at that time. And so they can say, you know, to cancel or to, you know, maybe we have to use an open procedure now.
That's fascinating.
Yeah, so we can actually go ahead and deploy our stent. So, and we're going to do it always under fluoro. And so now you can see it looks kind of like a barbell up here, and that's where our problem is. And now I'm looking at the pressure as it's increasing, and you're going to start to see that open, 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 open up. So we're now going to open it really wide, and that's going to close that area off, and now we'll pull it back down. Balloon's now retracted, and it's very hard to see, but you can see the outline of the stent and where it's deployed. So now we would do another angiogram, and you're going to see how we've opened up that whole space, and now it's a little open highway. So we'll shoot a video really quick. So I'll shoot a stent. And then we can compare it to our first one.
Oh, that's cool.
And then now they've got a stent, and now that blood vessel is now open, and problem is solved, and pull everything in.
That's amazing. And it seems so fast compared to if they had to do open heart, where they actually had to open the chest.
Yes.
This is a lot faster.
So cabbage procedures where they're doing coronary artery bypasses that use grafts, and that's where the cabbage comes from, are, you know, where you need to surgically kind of suture around a problem such as this, versus this is a more minimally, of course, invasive procedure where you're just going through either a small port, either in your femoral artery or even in your radial artery as well.
It's amazing. They can your wrist and do something like this, but that's for the patients who have had multiple surgeries and they may have too much scar tissue to be able to get through. Do they also use the jugular sometimes?
So that would be for the way that this blood flow, and you're talking about that going venous, you would have to, in reality, according, like anatomy, you're now going into the right side of the heart, and then you would have to go up and over pulmonary through almost the entirety of the pulmonary system back into the left side of the heart, out and up. And if you're looking at the coronary arteries, which are the first takeoffs after the aortic valve, so that's your big artery that feeds all your oxygenated good blood to the rest of your body, you're trying to, use the standard misnomer of shortest points as a want to go venous side and get arterial, because that's not the shortest way to go. So
now, what about when you have patients who have dextrocardia or something where their anatomy isn't what the normal anatomy is?
So that's why we were going to use that pigtail catheter at first. I took a big picture. They saw it and y'all didn't, but I took a big picture and I was still in the aorta. So we know anatomy. That's why you never assume that you can just go ahead and move straight towards your stent or straight towards your direct catheter, because it cause a bigger problem than you knew would existed, because everybody is not the same. And so you need to actually pinpoint and develop your therapy based on the patient that you are looking at right now, not the statistics that are generalized for the whole population.
That's excellent. And the more adults with heart disease that you see, you're going to see such a variety. You never know what you're going to have.
Exactly. So then you can, you may be looking at using one type of catheter or thinking that that's the one you use all the time, but maybe for this particular patient, we have to change the angle just a little bit. So
yeah, and I love how there's different sizes right there, so you don't have to stop everything.
Exactly.
Good for you. I know. I love it. It's
and
great.
It shows this. You can see if we had done a different procedure on this form. We can do STEMI procedures. There are times where we would need to give medications or defibrillate. This patient, you can still see has a slight ST elevations, but that's also due to what we were doing as well, and the fact that I still have this catheter in. But also, if this is a real life environment, not just a video game, on the sense of you have to pay attention to what's going on around you. You could be so focused, and we call it kind of target fixation, on fixing this particular lesion, that you're ignoring the vital signs that are coming out of your patient, so you have to be fully aware of everything that's going on.
Well, thank you for showing this to us today. It's amazing. Okay.
Lots of different video games. So it's pretty cool.
This is about lighting the match, creating the fire, basically, of interest and innovation. It's a meeting of the curious. This is a platform by which we can get together and we can actually share these ideas and share these concepts. And the solution really is the other guy's toolkit, making your knowledge transfer between industries. And those hills today are in petroleum industry, aerospace, and in medicine. This is called pumps and pipes.
This is not like your typical anatomy class from medical school. This is more goal-directed anatomy, so you know exactly what surgeries you're going to have, you know exactly what exposures you're going to be expected to know. So you go into the cadaver lab knowing exactly what you want to achieve, what you want to accomplish, and you go right straight for it.
Experiences such as this are very valuable because they make you a better technical surgeon, with people actually explaining what I'm looking at and how to get to that vessel or how to expose that portion of the aorta and what to put, you know, even in terms of retraction, how to retract things, simple things that make a huge difference, I think, when you're doing a 6-hour operation.
Having kind of time to take a step back from the chaos of the operating room and really tease out the finer points of safe open aortic surgery. And have an environment to kind of ask questions in a non-punitive way has been very, very fruitful for me.
The average vascular surgery resident or fellow in the United States finishes with only 5 open aortic aneurysm repairs during their training course. And so one of the gaps in training these days has been the switch from open to endovascular surgery. And so those patients that do still require an open operation, we're now asking the youngest surgeons with the least experience to do those toughest operations.
In the OR, when you're, you know, scrubbed in, people don't necessarily always verbalize what they're thinking or what's the correct technique. And I mean, this is amazing that we have such great vascular surgeons here that are willing to take the time to actually go over these technical aspects.
Of course, having Dr. Ide and Dr. Lumsden available, but also having group mates, your peers and people that you've seen along the way in the interview trail for vascular surgery, and then to be able to again interact with them and participate on the dissection, for example, and having a chance to learn from each other and cross-pollinate.
There are 0 reasons for you not to come. I think thinking if you already know your anatomy and you already know your exposures, coming here you refine these skills, and a lot of the tips and tricks that you may not get from your attending in the OR, Dr. Ite and Dr. Lumsden just grant them to you.
In our field of vascular surgery, with endovascular approaches becoming much more mainstream, open aortic surgery tends to kind of fall to the wayside. And I think in the grand scheme of providing the most effective and safe patient care, open aortic surgery is something that we need to have a mastery of.
Hello, I'm Dr. Faisal Masood, and I'm the Medical Director of Critical Care at Houston Methodist Hospital. I'd like to invite you to join us in Houston for the annual Critical Care Symposium. This special event will be held at Houston Methodist Research Institute in the Texas Medical Center. This one-day symposium is designed for the interprofessional critical care team. As such, you will hear diverse lectures from experts representing a wide variety of critical care topics. Then, after a morning of didactics, you will practice your new skills in expert-led hands-on workshops or breakout sessions. You will leave Houston Methodist with the confidence to apply these skills in your everyday ICU practice. For further details, visit the website. Caring for critical care patients is a team effort. So we have created this conference for the entire critical care team. So if you work or train in the ICU, this course is for you. I hope you will join us and look forward to seeing you in Houston in January. Thank you.
Heart of a Woman is such a unique event because it's open to not just the public, but also healthcare providers. So the audience is a mix of all different learners. I think the speakers are also a mix. So you not only get to hear from the cardiologists, but you also get to hear from the mayor, and you get to hear from chefs and dietitians and different people who are experts in their field. So you really get a well-rounded message about how to take care of yourself so you don't develop heart disease.
I decided to dedicate my Saturday to Heart of a Woman because it's a one-time-a-year event.
Once the excitement went away or settled, I had that moment where I went, I'm pregnant and I'm in a new town. I don't have any doctors. What do I do now? So I found a congenital heart doc because I already had that appointment. I found an OB. When I walked into that appointment with my pile of records, she looked at me and she said, all right, sum it up in 2 sentences. I went to an MFM doctor who had previous Fontans as their patients. I saw 2 MFM teams because I wanted to deliver at the hospital with my adult congenital doctor. One of the appointments I went to, the MFM doctor said, all right, your baby looks good. You can deliver in Monroe. You don't need to come back to see us. At that moment, I realized that part of being a patient is knowing, okay, I have a whole team of doctors. We're all on the same page. And if there's somebody who's a little bit off, go with whatever the plan was. So I said, thank you. And I got an appointment for 2 or 3 weeks later. So my big thing is your cardiologist may know your heart, but often the defects are so rare, you have to be willing to educate your doctors. Don't be afraid to advocate for yourself. And I think this panel right now is so important. It's like my passion as a nurse was to teach our patients their diagnosis. And so I'm really excited to introduce our panelists. So if y'all would quickly introduce yourselves, and we'll go from there.
I'm Anna Jaworski. I'm a heart mom. My son is 25 years old and was diagnosed with hypoplastic left heart syndrome, and he's post-Fontan.
I'm Joe Valente. I'm a board-certified patient advocate and also a tetralogy of Fallot patient.
I'm Ashley Reef. I am the nurse coordinator for the adult congenital heart program here at Houston Methodist.
I'm Eunice Carranza, nurse practitioner here with the Adult Congenital Heart Program.
I'm Gary Montero. I'm a cardiac anesthesiologist here at Methodist with a interest in adult congenital heart disease.
My name is John Breinholt. I'm a pediatric cardiologist and interventional cardiologist. I work with Dr. Lynn here doing procedures at Methodist.
All right, so I warned Anna ahead of time that I was going to ask her a hard question. As a mom, how do you transition, get your child to be educated about their defect, and how do you give them ownership of their?
Yeah, that's a really, really good question. So when you write a book called Hypoplastic Left Heart Syndrome, a handbook for parents, and your children see it all the time and hear you practicing for speeches that you're giving, your child learns about it. But it's kind of one of those things where we go in one ear and out the other. So how do you make them interested in learning about their heart defect and wanting to take ownership? I think that my son's experience was a lot like yours, in that it wasn't until he was facing surgery and it became much more real. All of a sudden, those stories that my husband and I had been telling him became more salient. And then he realized what he needed to do himself. Sure, he knew the words hypoplastic left heart syndrome, but what did that really mean? He had his first 2 surgeries before he was 1 year of age. He had no recollection of that. But having surgery again as a teenager, everything was different. And I think he thought it was going to be a much easier course than what it was. It sounds like you had a really tough course. We were in a hospital for 26 days with him having pleural effusions. All of a sudden, now his heart defect was much more real to him, and that scar that he had had for so many years was a totally different experience for him. He used to kind of hide his scar, but after his 3rd open heart surgery, because he had to have his Fontan redone, he was wearing V-neck shirts and he was really proud of it. It was really awesome. So I think it's, we started by talking to him about it regularly. Every time we went and saw the cardiologist, we talked about how he had to see a cardiologist, but his brother did not. He needed to know that what he had was different than what Joey had. And I wanted Joey to be a powerful advocate for his brother as well. And so we didn't hide anything, and we used real words. We didn't try to dumb down. I mean, even when he was 4 or 5 years old, he knew HLHS. He may not have known hypoplastic left heart syndrome, but he knew HLHS. And we had a medical alert bracelet as well. So we had exposure on a lot of different levels. But I think it was him having surgery himself as a teenager where he wanted to own it, just like you talked about yourself.
I actually have a question for Anna as well. It's along the same lines. Were there things that your son's providers could have said to you or to your son that might have helped in this process? And what can we do? How can we be of aid in helping him take ownership of his disease process?
Well, I think you have to realize, and I think Chris would probably agree, and I think Joe would probably agree too, they don't want to be diagnosed. They don't want to have a label put on them, and they don't want to be the poster child for whatever their heart defect is. So, or at least that's the way my son taught to me. Even though I had written a book and I was giving speeches, I actually took about 10 years off from speaking publicly about it because he didn't want me to do that. And I felt like I needed to honor what his wishes were. What could the doctors have done differently? I have to say, we had the best doctors. And the doctors that my son saw had sons themselves, and they treated Alex like he was one of theirs. They would talk to me, yes, but they always spent time talking to Alex as well, drawing diagrams, making sure that he understood as much as possible. So I really don't see how his doctors could have done a better job. He didn't want to take ownership before because he wanted to be just like everybody else, and he didn't want his heart defect to define him.
Any other congenital parents in the audience? Are your experiences similar to those of Anna?
No, because my son has Down syndrome. Okay. So
he will probably never cognitively be able to take ownership of his defect, and he will always need someone else assisting him. So it's a little different situation.
Anybody else? How about your daughter? We talked about her upstairs just a second ago.
Right. She's not really want to talk too much about it. She has not been. She's kind of, I guess, afraid of it, I guess. You're kind of scared for her.
Interesting. So you think, having like a peer group, perhaps, of other congenital heart patients might have helped them to become more comfortable with it, helped to normalize it, helped them not to feel so different or unique?
I don't know what Chris and Joe would say. I offered my son camps, and he never wanted to do that because he didn't want to be identifying with other people with their heart defect. Now, he didn't have a whole lot of choice at times because I was getting together with other parents and they would have their children, so he had no choice but to socialize with some of those kids. And I think that was probably a good thing because it was a more natural thing. It was the parents getting together. It wasn't us saying, oh, we need to get you kids together. It was the parents getting together, and then they just got together because, well, we were all in the same room together. But as far as like going to a camp, my son didn't want to do it. And I think that's just a matter of who he was. I think if my firstborn son would have been the one with the heart defect, he's Mr. Social Butterfly. So he probably would have loved to have gone to a camp. But it just so happens that the child that I had that had a heart defect was my introvert. And that just wasn't something that he felt comfortable with.
Such important information. Okay, sorry to interrupt. Oh.
Level when you become the mom. Like me, I'm cool, whatever. But my girls. So how did you deal with the stress of like what's to come? Like knowing that your child's gonna have repair and knowing what complications your kid's going through and just being different than most of the other little kids. How did you overcome that? Did you just have a really good support network or what did you do?
That's a really good question. My husband is sitting over here. He is my biggest support. He's a nurse. And that was a huge help to me because I was a teacher and I didn't know all of the anatomy. I didn't know all the terms. There were so many people that we were meeting, all these different doctors. And yes, there's a lot of stress. So how did I deal with it? I have my husband and he and I are really good communicators. And if I didn't understand something and he understood it, he would explain it to me. If neither one of us understood it, once again, we had these excellent doctors who we could contact, and they also had excellent nurses. They were really good about explaining to my husband and me what we needed to do. But as far as the stress, oh my gosh, it doesn't matter how good your support system is, you're always waiting for that other shoe to drop. I did seek counseling at times when it was overwhelming. For example, there were 4 children in a hospital at the same time with HLHS when my son had his first surgery, and we were given bad statistics. We were told that probably only 1 in 4 of children survived at that time because we are talking 25 years ago. And within 16 months, 2 of those children had passed. So it was extremely stressful for me, and I think we were always waiting to hear if Joshua was still going to be okay or if something was going to happen to Alex. Even though I'm a math teacher and I know I couldn't apply statistics to that teeny tiny group, it was still scary. And so when it got to be overwhelming for me and I was just extremely sad, I ended up going to see a counselor, and that was one of the best things I could have done for myself. I know a lot of my friends have also gotten on antidepressant medication just a little bit to help them. I think you have to do what's right for you.
Thank you.
All right, so let's see. Ashley, so how do you educate the patients and their parents about their defects?
I think the most important thing, and those of you that are parents of children that have congenital heart disease, I think you'll agree that in the pediatric population, obviously you're the one receiving the majority of the education and the information. Having been lucky enough to work both in pediatrics and adults, I kind of find myself talking to who's in the room, parents, if there's a grandparent there, as well as the patient. I use a lot of diagrams. I try to send patients home with written information, as well as sitting with them during their visit and going over their defect. I have a couple different resources I teach from. I try to use things that are colored so that they can understand the original defect in terms of red blood, blue blood, purple blood when it's mixing. And then I also try to provide images of kind of basic representations of their repairs. I think the most important thing is to also talk about the other things that happen from a cardiology standpoint. We talk about heart failure. I'm usually not their favorite person when I'm talking about heart failure, because I usually talk about fluid restrictions and low sodium diets. But at the end of the day, it's all about continuing to provide the same information, reinforce that information at each visit. And then even over the phone when they call and they have a question, we also request a lot of weight logs and blood pressure logs. And each time that they supply those, we try to do education as well. So I feel like educating them at every kind of point of contact is most important.
ECHD patients in the audience, how do you best understand your heart defect? What has worked for you? What can we do to help you understand it better?
I think just being upfront and honest. Just being upfront and honest. Don't sugarcoat things to us. If it's bad, just tell us, hey, it's bad. Just don't tell me like, oh, don't lead me on to something that it's not.
Is there any way, do you like diagrams? Do you like, I guess everybody's a little bit different. Some people are auditory, some people are visual learners. Is there some preferred way for learning or something that's really worked for people, some resource?
I can agree with seeing it.
Seeing it. So we need Tom in everybody's clinic to drawing diagrams. All right, thank you very much for your input. Sure.
Maybe Joe can address this question. You know, in San Diego, when we started partnering with the ACHA, doing the CHD conversations, it's every 2 months or so. We get the patients on a Saturday and we talk about a topic. We have a speaker. You know, what's fascinating is patients were not coming for the speaker. They were coming to see each other, because most patients I've discovered that have never met someone else who's had congenital heart disease and had heart surgery when they were little. And you know, everybody's conception about heart surgery is an 80-year-old person who's having bypass. So my experience, and I don't know what you think about these types of venues where people can meet and talk, maybe there is some education from peer to peer that need to happen as well.
Yeah, I think that, you know, probably a lot of us, I know at least for myself and probably a lot of people in my generation, we grew up not really knowing anybody, maybe, you know, 1 or 2 kids in the school or whatever that also had a heart surgery or whatever, but it was, you know, few and far between. And now with social media, we're starting to connect with a lot more people, and the kind of the world is becoming, you know, more connected and smaller, and so those connections and meeting the people is becoming better. And you know, we have events where we meet up and you know, we go out and have drinks and those kinds of things. So you know, meeting people and talking about things is great. And I think that it's interesting to see how different everybody's experiences are, but also, you know, how similar, you know, things are too. You know, the experiences from everybody, and I should say complications, but you know, some of the struggles we have are very similar, you know, no matter where you are. So a lot of us I call it we're in limbo, and we're in limbo between an adult hospital and a children's hospital. and it's a big struggle for us because the children's hospitals are great at taking care of our cardiac needs, but they're terrible at taking care of the rest of our needs. And the adult hospitals are great at taking care of the rest of our needs, but are horrible at taking care of our cardiac needs. And so, who's the best at taking care of me? And it depends on what's going on, right? So, and it takes the patient to understand what's going on, and so I often say the patient has to be the best triage nurse there is, right? They're the pre-triage nurse because they have to do the triage before they even get to the triage nurse at the ER because they need to know which ER to go to, right? Because if they walk into the wrong ER, they're not going to get the appropriate care. So, because, you know, if they go into an adult hospital that doesn't have a congenital heart program, they're not going to be able to care for them. And very likely they're going to provide the wrong care for them. And somebody's going to be coming behind them to pick up the pieces. So it's a tough battle, but you know, those are the things that, you know, those groups meeting up with people, those are the experience things we talk about, and you go, oh wow, yeah, you know, we share those things, and that's kind of, you know, the interesting perspectives that you start to go, oh, I'm not alone in that. So it's cool.
Can I jump in with a question? So does anybody here have a really great systematic way that they keep track of their medical records? MyChart. Okay, great. Anybody else? Does anybody use MyChart strictly for their medical records? Like they go to their doctor, they say, here it is, MyChart. Raise your hand.
Say that question again?
So the question is, does anybody have a really good system that they're, you know, willing to brag about as far as the way they keep their medical records and what's happened to them in their lives?
Yeah.
All right, let's hear yours, Joe.
No, I keep all my medical records. So I have multiple methods. I obviously have all my medical records, you know, on a CD and also on a thumb drive. That's, you know, the whole shebang, but that doesn't do you much good. But then I have all the medical records sorted down to a smaller file, which has the most relevant H&P, and then, you know, my most recent cardiac MRI, you know, EKG strip, echoes, all those kinds of things, as well as images, not just, you know, reports. I like to have the images on there as well. And then I have a tab delineated binder with all that information as well. So anytime I go to a new doctor or anybody, I can just hand them a binder, flip through it, have it on a thumb drive. I also have it in the cloud on my phone, so I can email it to them.
Does anybody else have that here? I don't have that for my own medical records, but that's pretty phenomenal.
But it saves a ton of time. It saves hunting and pecking for stuff. And, you know, when I transferred my care from UCSF to Houston, it took me about 2.5 years to really reestablish care. I was there for 35 years, and it was a lot of work, but every time I walk in a new doctor's office, I had my binder, I had my thumb drive, I had it in the cloud. However they wanted to get it, I had everything there. And, you know, it saved me a ton of headaches. And, you know, anytime anybody wanted anything, you know, well, what was your LVID on your last echo? There it is, you know, boom, done. Like, you know, it saves hours on visits, you know, or come back next time and we're going to find this information. No, it's right here, you know.
So I want to take advantage of the fact that we actually have Dr. Breinholt on this panel and Joe and Chris all here. Because I think the issue at the end of the day for us on the adult side is we're on the receiving side, right? So I guess, Joe, Chris, when you guys made the switch to being adults all of a sudden, I mean, how did you go from being in the pediatric world where you probably didn't have your records, or at least probably your parents kept your records, to all of a sudden you're the one keeping the thumb drive, the binder, and the cloud? I mean, how did that work? And Dr. Breinholt, do you have any suggestions how we can make that happen?
You know, as I was hearing this, it made me think about what everybody believes is the way that you do it, which is you go to your new doctor, and then your doctor makes a request for your medical records. And I can tell you that that is a particularly slow process. And I remembered after I moved here, I had a patient come to me, actually a patient that you referred to me, Huie, and it was the daughter of a patient that you referred to me, and we were trying to move things quickly, and I told her how I needed to get some information, like the most recent echocardiogram and things like that, and then we could request it. And this mother was very well versed. She had her own heart disease, and she walked down the street and secured the medical records from the other hospital and brought it back to me the same day. And I thought, well, that was about the most efficient thing I've ever seen. So I think that whether or not it's as meticulous as what has been described, having information with you to educate us when you arrive, because it happens to us, even though I'm not on the receiving end like you are that do adult congenital heart disease, I'm usually on the creating end of things. I do receive patients, and I think it's pretty universal that what we find out, the more we can find out, the sooner we find out, the more that we can, the more productive we can be for you. And I think that maintaining, at the very least, most recent information that you have is unbelievably helpful. Your last echo report, your last MRI report, your last clinic note. If you just have that, and your doctor actually maintains decent clinic notes where it actually has some of your history as far as what surgeries and when, it's unbelievably helpful.
I would add to that. I suggest your medical records are your legacy, and as a patient, I would get them often. And the hospitals, if you transfer your care, you may not necessarily go back to that hospital years later and have your records there, right? And so you want to get them and have them. We're this day and age, I got the copy and paste HMP, and you get a copy and paste HMP that's bad, it's going to be in your record for a while. So you want to be able to go back to an old HMP that's right. You need to be able to find it, right? So you want to be able to go back as far as you can to get to the right thing if it's wrong. So I like to have old records that I can look back at. And a lot of my pediatric records are gone because they were too old and I never requested them. And that was back in the paper days, and I know things are changing with electronic medical records and whatnot. But, back in the day, I know my dad's a doctor, and when records were old, we used to shred them, and I sat there as a kid shredding them. They're 7 years old, we'd shred them, right? And so I think of that in my head, like, okay, I want my records, keep requesting them. But, it's hard to get things out of your record once they're in there. So it's your legacy, it's your story, right? It's just like your family pictures. Get them, have them on hand.
I think that's actually a really good point. What was coming to mind was an experience that I had with a patient whose heart disease was quite complex. And what I had in front of me, which was the most recent information, didn't seem to relate quite like it should to what I thought the person had. And so I had to go back through all of their medical records, and it wasn't until I went back about 15 to 20 years that I realized that a mistake had been made, and that mistake was perpetuated for the subsequent 20 years. And so I finally figured out what the patient had. I figured out what surgery they had and when, because that was also unusual, because they'd had an unusual order of things. And it took 20 years to correct their medical record. And I can tell you, not many people do that. I don't know, some of us are, I think a lot of people, as they're listening to you talk about, you have it on a flash drive on 6 or 7 different forms of media, and everyone's going, yeah, this guy is a little obsessive. I'm the physician side of that, and so it takes if there are a few of us out there, I think, that would go through and track all the way back. And I was fortunate enough to be able to find it, and it was not easy. It was a mention of something that gave me the sense that there was something wrong. And so I think that taking control of your medical history is important, because again, it comes to where when you have people like me who is going to do a procedure on you, you really want me to know what you have so that I can plan accordingly.
So I personally keep my surgeries and my caths in a paper folder, and I have one copy in my safe, and I have one copy in my car, so if I ever go anywhere and go, oh, I forgot my medical records, it's with me. Now, if my car gets stolen, I'm kind of in trouble. But I keep that with me. And then, like Dr. Lynn was talking about the My Chart, is I actually do use that. I had a kind of rough delivery with Harrison, and the OB said, well, did you develop HELP syndrome? What was your platelets? And if it weren't for being able to show her my chart where she could see my labs, she kind of wouldn't have been able to figure out what had happened. So having my chart does help, and you can look under the letters tab where they send the letter to your regular doctor, and you can see what they wrote. And I look at that all the time, and so I don't necessarily have to print out a physical copy of my note every time I go to the doctor, because I do have it there. Now it's kind of limited what you see, so you still want to request certain things like echo reports, stuff like that. But my chart is very useful because you typically have your phone with you.
I'll bring you a microphone.
Can I say something while you're walking over there? When my son decided he wanted to go to college and he did not want to stay in Texas, he wanted to go to New York City. So there's a big time and distance between New York City and Texas. I was concerned about this. He was going to have a brand new doctor that was there who had never seen him, didn't know anything about his history. And so I actually talked to his doctors, and we put together a thumb drive, just like what you're talking about, that had all of the images and everything. I made sure he had a copy of that. I made a duplicate copy of it and sent it to the doctor. And I, thanks to email, was able to introduce the doctors to one another. And my son never had to meet with that doctor. He was able to come home and meet with his regular doctor. But if something would have happened, I knew they had all of those records. So for those of you who might be parents right now who have children who might be going off to school, this is something that you can help them to do. And so my son still has that flash drive, and I just think it's important for them to have that.
So from my experience, actually one patient pointed that out who works for Epic. He told me, you can share the note with me. There's a button, and if you share it with me, then I have it in my chart forever. So I started doing that with my patients, and we all write exhaustive notes, summarizing the past histories. It takes us hours to go through the paper records. So I like to think that the clinic note has 95% of the information that is required to deliver, any level of care. Unless a surgeon, wants to look at the actual, detailed operative report, I think the clinic note should carry most of the information. The other thing to say is, Thailand has a national healthcare system, and the government mandates that basically every patient carries a government-issued thumb drive. And they mandate that all the hospitals have whatever electronic healthcare system they have, that it's compatible with that thumb drive. And before the patient leaves their doctor's visit or leaves the hospital, they plug it into the system and it gets uploaded or updated automatically. So maybe someone who has, the intellect and the drive could talk to the ACHA or some other organization. Maybe we can create something like this for our patients that is secure and HIPAA compliant, and also can communicate seamlessly via the cloud, so that you're not just having one physical copy.
When you talked about your son going away to college, it made me think of something that before I say what I'm about to say, I do think it's really important that we want, and I'm sorry, I'll talk about patients like your children as opposed to sometimes it's you, but I always tell the parents of my patients, my goal is for their child to have a normal life. And so there are some circumstances where the repairs that are done can give them essentially a normal life. Sometimes there are going to be some caveats, but nonetheless, our goal is to maximize what they can do. That being said, I think there are a couple tips that are helpful. We're talking about some of them by knowing what you have, having your records. One of the things I would add to that is when you travel, when you think of where your destinations are, know where you should go if you have a medical emergency. It's going to vary depending on where you go. As a pediatric cardiologist, I make it pretty simple. I say, know where the children's hospital is, where you're going. In your case, if, as an adult, you may need to know where is the hospital that has the facilities that's either an accredited program or that's going to have an adult congenital specialist who's going to understand your heart disease. It takes away a little bit of that having a normal life, I understand, because I know that when I travel, I don't think, I wonder where the nearest hospital is, but knowing that you can be somewhere where all you have to do is be able to tell whoever is taking you, this is where I need to be, it can really be a big difference between whether you get proper care or whether you get, what could be catastrophic care.
I would like to add something to that, too, about your medical records. I'm an emergency room nurse, and a thumb drive is wonderful. But when you come into my facility, if you can not tell me, or if you have it in paper, like a sheet of paper that has your list that you can hand over to us, it's so helpful. And that way we can direct your care. And then the other thing I'd like to consider, if there's something specialized about your care that, say, not every single nurse in the world would know about, it's something you need to remember. Like, for example, if you have a shunt that's open, you would use a certain filter with your IV tubing. That's something that you should bring up to your nurses, even in the ER setting, because they may not know, and your physician may not even know.
I was going to ask an unrelated question, but Joe, you had mentioned social media and kind of making the world smaller that way, and I think by and large it's positive. The problem I've had with some patients is this ability to know about every bad outcome that occurs throughout the world. I mean, a kid in Thailand has a bad outcome, and the anxiety and the stress that can promote in patients. And how have you guys kind of counseled patients in regards to Facebook pages and those kind of things?
That's a tough one. I think I wrote a blog sort of about this, the race to who is sicker, right? Because I think that there's some sort of competition, and there's a badge to this of who, and it's in the adult population and with the kids. Like, my kid's more severe than you, and it's an odd phenomenon, and I think part of it too with adults I see is part of the problem that goes more to the clinical side of it is the risk stratification that we do with the kids when they're infants, right? You're a critical CHD. Now they're an adult. They're using that, I'm a critical CHD, or I'm a moderate. Maybe they're using that as, either to the positive or to the negative, right? Like, I don't need to go see a doctor because I'm a simple CHD, right? And so, I mean, we look at it, pregnancy. Who's the highest risk for having problems with pregnancy, right? Like a simple tetralogy who's not going to their doctor, right? And they end up 6 months pregnant, and now all of a sudden things are hitting the fan, right? So it's like, okay, we don't have a good system. I mean, we look at the clinical guidelines. If you want to show the patient clinical guidelines, it's like, that's way over their head, right? Your class D physiology, but whoa, right? And so everything is about kind of this, I don't know, I call it a badge or whatever, but it's like comparing people to everybody. And so that's the thing with social media that's like sort of the negative about it. And I think that people really hold on to this where they're placed in that. And for the adults, they don't understand that it's changed and that their bodies are changing. Is it change for the better, or it can change for the worse? And they don't understand where their body is fitting into this. And kind of going to what Dr. Breinholt was saying with traveling, I think it goes into where you're living. And I see some of these patients that are really sick, and I look at where they've decided to move somewhere. And I understand, maybe you only have means to live somewhere, but they move into places in the country that have no care, and it makes their lives harder. And then they realize that once they're there, as a patient, I don't feel comfortable not being somewhere where I know that I can get appropriate care. It's not comforting, and I know other patients feel the same way. Like, where am I going to go if I get in trouble? And so I think it's the you have to have some foresight, and I think it's looking as a parent, counseling your kids about where you're going to school, where you're going to go to college, and these kinds of things, where you're going to settle down for your life. Like, what are the resources where you're going to college? Is there adequate, care there? Maybe where you go to college is where you're going to live the rest of your life, right? So those are things to think about. I mean, it doesn't have to dictate your whole life, but definitely it should be one of the things you talk about.
I was just going to reiterate two things. One was that in the spectrum of when patients travel, when people travel, our lives are becoming more and more mobile. I think people are moving to different places for jobs. Not everybody is staying in one place for 30, 40 years. And so we see that a lot. I think it is incredibly important, not just with your vacations, but if you are moving somewhere, whether it's for a job, whether it's for college, whether it's for graduate school, whatever the reason is to establish care in that location. You should always keep your home base. If that's, you've known those people for a while, that's incredibly important. But it's good to create that in communication with your doctors while you're there. Because if there is a place that you're going that has an ACHD clinic, they should hook you up with them. If they don't, and they're in a small place, and sometimes life puts you to places where you've got to go, right? Then at least they can be like, okay, find a cardiologist there. Here's my cell phone. I want to speak to them. Let's start the communication channels. You're going to be there for 4 years or 1 year or 2 years or maybe indefinitely, and let's kind of figure it out. This will be the nearest ACHD clinic, 3 hours away. This is who you're going to go to for specialization. But that setup, and that's where it takes work from your provider, but it also takes individual initiative. So it takes all of the above to make that happen, and that's where I see, we have patients flying back from places all over because they're traveling and from Florida and such to come to see us, but you have to have somebody local. You can't just do, because if problems come, it can be unexpected. And if it comes unexpected, you have your records everywhere, which is phenomenal, and having them like that, I mean, that's a beautiful thing for a provider. But I just want to reiterate what Laith said, because I think the MyChart, the ability to access the most recent note is the most crucial thing, because that is the up-to-date. And you can check it. You can double check and make sure that it's the truth, because it's your information. You should have access to it. Ask your provider to get access to it. Because if you are vacationing in, let's say, Florida, something happens, well, guess what? The internet is everywhere, even if you may not have your USB that day, or if your car broke down or something. So that is the one thing. And we haven't talked about privacy concerns, but there are patients I have who have significant privacy concerns about putting it in a USB that's not protected, I've had these conversations. The nice thing about MyChart is that it is a login, it is medically secured, encrypted, as much as anything can be in the modern day.
Any other questions from the audience? About this topic?
I don't have a question. I just wanted to make a comment. First of all, I want to congratulate all the patients, or prior patients and physicians, because I've been a nurse for many, many years, taking care of many children, infants with congenital heart disease, and I'm amazed to see that they're grown. Also, when I was practicing as a nurse in pediatric ICU, one of the things that helped me, which probably they don't do anymore, is that the physicians where I worked, they had a picture of the heart defect, and because not every single defect looks the same, and so they always had a picture of the original defect and what it looked like after they did the surgery.
Like a Mullins diagram on the chart, maybe? Or?
Just another point about the operative reports. For those of us that are surgeons, having access to the original op note is really helpful, because, as we talked about this morning, a fontan is not a fontan is not a fontan. And so for planning, it really does help to be able to read in the words of the surgeon who did it what exactly was done. Sometimes it's hard to get them looking back 10, 20, 30 years, but if you have them or if you can get them, it's very helpful.
There.
Ashley. You were talking about patient teaching. I'm interested in what you would suggest that nurses be taught, specifically patients who are born with a congenital heart defect. As they age, they're actually going to develop what you think of as more normal or typical heart problems, things that the general population develops. So my question is, do they present differently? When I'm interviewing a patient, am I going to see a different set of symptoms with a patient who has a congenital heart defect, but they're now developing sort of adult heart problems?
Well, I think it's going to kind of be, you'll see the combination of the two. So you may see the result of what their congenital defect is, but you also will tend to see the same things that would happen with, say, high cholesterol. That's still going to be, if that is what we're worried about, then we're going to see that, but we're also going to have to think about what is the patient's congenital defect. I think it really depends on the defect, whether they are a single ventricle or whether they have both ventricles. But I think that's why it's important for the practitioners to have that knowledge, that it is a congenital patient as well.
Will their symptoms appear more exacerbated because of their congenital heart defect?
It depends on the symptom, but not necessarily.
Okay.
Some like blood pressure at time, depending on the defect, they could have high blood pressure because, say, they're coarced and they have a recoarctation. You could see high blood pressure because of that, or they could be simply developing hypertension.
Now, I was going to say, I really want to hear Dr. Montero's perspective on this topic, just because he is an anesthesiologist.
Yeah, it's actually a fascinating question when adult patients who have adult congenital heart disease start to develop acquired heart disease, senile aortic stenosis on top of another diagnosis, or coronary artery disease, sort of our bread and butter. When you're in the pre-op clinic and you ask the patient, are you able to walk up 2 flights of stairs? Is it because of residual congenital heart disease, or is it because they have symptomatic coronary artery disease? And you don't know. You really don't know. That's where imaging modalities come into play. That's sort of our quick and dirty question about someone's cardiac function is, are you able to do 4 metabolic equivalents, walk up a flight of stairs, this kind of question. And in our non-congenital heart patients, they could be limited by respiratory disease. It couldn't be something other than cardiac disease. It could be as simple as deconditioning. But in our adult congenital population, it adds a whole nother layer of things that we have to explore. They may require farther testing based on their symptomatology, which is sort of how we think about it in the anesthesia pre-op clinic. We'll sort of look at comorbidities. We'll say, is this patient able to go through the surgery metabolically? Or can they walk? Are they short of breath? Do they have an arrhythmia? Do they have valvular heart disease? And a lot of our patients are going to have, some degree of mild to moderate valvular disease. And usually, if you can't tease out the symptomatology, then we're typically refer them to farther preoperative testing. So.
I just wanted to, because we're running out of time for this part of the session, I want to summarize and get the panel's thoughts on this. So it seems like the really critical things to take away from this, for those of you who have kids or are patients or have family members, have to have a copy of, whether it's paper or electronic or both, a copy of the operative reports, a copy of the cath reports, preferably the latest imaging, whether it's MRI or echo, and then a relevant, good clinic note from the last congenital heart specialist, even if it is the pediatrician. Anything to add to that?
Anesthesia records.
Anesthesia records. What kind of anesthesia records, just so we know what to look for? Because I don't know what that means.
I mean, there's in your medical record, probably shoved behind the surgical note is in the past it was a paper record with a lot of little hash marks on it was blood pressure, heart rate, this kind of thing, medications used. In the monitor, most are transitioning to electronic records. But a printout of the medications you were given, we can see your blood pressure responses, sort of its own language, but the anesthesia record itself, which is separate from the surgeon's notes, should be part of the medical record that you can get a copy of. And it's super helpful to glance out from an anesthesia perspective ahead of time.
I would add to that for the echo, for if you're actually getting the images, often hospitals may have it in the echo lab, echo library, that you have a separate request for those. So if you're pulling your hair out, not being able to get them from medical records request, you may have to go that route.
I just wanted to stress what Dr. MacGillivray said about the operative reports. I think one thing that patients may not be aware of is that hospitals sometimes don't keep records for more than 10 years. And if they do, sometimes they get sent to storage, so it can take weeks for us to retrieve them. And even though we have a great team that works really hard, and Ashley leads this, trying to get all these reports, sometimes they're really, really hard to get. So having that, I think, is a key piece to safekeep, because it may be really hard for us to get it, and most importantly, hard to get time in a timely manner, because if you're going to the OR soon, we may not have the luxury of waiting for weeks to get it, and it's crucial. And Dr. Montero, I learned something, and we're gonna add that to the list that we request. We're all getting educated.
So I think we're going to move on to the second portion of this, which to me is going to be a little bit more deep. We're going to talk about advanced care planning. I know there's a few different people.
Yeah, so why don't we bring up the panelists for the next panel? And then if I can get everybody to do me a favor, can I have everybody stand up for a second, just because we've been sitting for a long time. And then everybody who's in the back, if you're willing to come closer to the front, because this is where it's going to be really important that we actually have everybody together, because we really want to keep this as interactive as possible. So pick up your stuff, people in the last 4 rows, bring it up to the front. Come on. We'll rope off the back like in church. Welcome to stage. I am going to hand you the mic.
Are you running this panel? Okay.
Thank you for complying with the move forward. I appreciate it.
Work. Oh, it looks the advanced care planning stuff. It's really hard to find anything.
Yeah. But the email that I got, who was Chris? Oh, you're Chris. Okay. Chris said we didn't. I had a few things, but I think she said she's going to field questions from the audience. Yeah.
Okay, so we do have Keisha real quick. Do you want to introduce yourself since you're our addition?
Yes, I'm the newbie up here, right?
Yeah.
Hi, my name is Keisha Foxworth. I am a newly added social worker to the congenital heart team with Dr. Lynn and Dr. Duarte to address some of the psychosocial issues that they're seeing in the clinic, and also to work with some of the pharmaceutical companies about getting the medications that some of these patients need if there are some insurance issues with their insurance.
All right, so this portion of the session is about advanced care planning. And I've asked Joe to kind of give us a rundown of what it is, because he, as a patient navigator, he deals with this a lot. And so I've asked him to kind of educate us.
Yeah, I wouldn't say I deal with it a lot, but I do. Yes, I do deal with it. Definitely. I think this is kind of one of those things that topic people don't really like to talk about. And we often associate advanced care planning with, death and dying. And I think the first thing I like to tell people is an advance directive is not a DNR. And creating an advance directive does not mean we're dying. It is setting up a plan so that when we cannot speak for ourselves, that somebody is empowered to speak for us and knows what we want done when we can't do that for ourselves. So, and as healthcare providers and as parents to patients that we want to provide these healthcare to have these advanced directives, the first thing I tell everybody, and same thing for the patients that I work with. I think if we don't have one ourselves, we can't expect them to have one, right? So the first thing we have to do is do it ourselves. And I think going through that process of doing it for yourself, then you really dive into it and learn it. And so you're better able to advise people on how and how to think about it, because you're forced to really get into the details. And so, as a patient advocate, I was, try to figure out what organization is doing things that we're trying to do in what space. So actually our friends at MD Anderson are obviously in the cancer space great at this. And so they have a great advanced directive planning tool. And I find it interesting because what they have is a step-by process of ranking different activities from 1 to 10 on how important they are to you. And so you can go through there and real quickly, how important is it for you to, simple thing, be able to talk, be able to, hold your grandchildren or whatever. And so gives it, really empower people to understand what's important to you, what's your quality of life. And so I think that's a great tool for people to use to get started. And then, so that kind of gives us the global aspect of your advanced directive. And then there's the kind of the more micro part is, what kinds of things do you or don't you want done? And this is more like, do you want artificial nutrition, TPN, or, do you want to be placed on ECMO? Do you want, to be on, a respirator and all these types of things? So if you go through it and some of these things, maybe you don't really know the answer to, and that's okay. You don't have to go into that much detail if you don't want to. But I think that the way I like to think about it is you're in this space and you're thinking about this in a calm, right? And if you're really sick and your family or whoever you've made your healthcare proxy to make these decisions, it's not going to be happy times. So try to make a thoughtful decision now, because they're going to have a hard enough time making these decisions then. So, and there's going to be some gray area in it, but try to take the weight off of what they're going to have to be doing, right? So I think there's and then the other kind of the last aspect of it is who will be your healthcare proxy. So who's going to speak for you? Who is the person that's going to speak for you? I think that as congenital heart patients, our parents have always played a critical role in our care. Mm-hmm. And I think that, once if we are married, that that relationship is, it becomes a little bit, it's not so clear who's going to be in control, right? So I think it's really important if you're married that it's, clear cut who's going to be in control when things happen, right? Because and it doesn't mean that that everybody can't be collaborating, but you need to, you need to have a clear-cut leader. And I think that also it's not only for your advanced directive, but I think in your general life, I like to call you need to have somebody as your quarterback for your care, right? Somebody you can go to And I always think it should be the person in your life that has the best clinical skills that can be your quarterback, right? So whoever that is, mine is my sister. My dad's an MD, but my sister's a DMP. She's the best clinician in my family, okay? My dad's too emotional because he loves me. My sister, she kicked my ass, excuse my language. But, it's like, okay, so I want her making my decisions, And so, it's just whoever fits that role best for you. And realize that when they're in that position, that if they're too, if they're too emotionally involved, then maybe it's not the best for you. And I think with CHD too, there's a lot of us are young. We're young, and I think the misconception is, oh, you're young, we're going to do everything to keep you alive. And I think a lot of us, I'm 37 going on 87, right? And we've been through a lot, and no, I don't want you to do everything to keep me alive, And so there's that education, and I think you really need to talk with your family about what does this look like. Well, if you got to take care of me every day for the rest of my life, I don't want that, So it's just making sure you have those conversations. And then the last thing I would say is this is a living and breathing document, right? It's not set in stone. You can come back to it anytime you want. You can change it. You can do anything you want to it. And I think that anytime, I like to, go over it every year. Like if you have your annual cardiology visit, it's a great time to go over it. And then and anytime you're having a procedure. And so that gives you time to, if you're going to a cardiology visit, maybe time to talk to your doctor about it and those kinds of things if you have any questions or things you're thinking about. And then also make sure it needs to be, if you have an advanced directive and it's sitting in your drawer at home, it's not doing you any good. Nobody knows you have it, right? So you better have it on file at all the hospitals that you might be going to, right? If you end up in the ER at a hospital, nobody knows you have it. It doesn't do any good. So make sure your family has it. Make sure it's on file at all the hospitals, right? Even if you don't go to the hospital there, make sure it's on file. That a hospital you may be at. If it's your closest ER to your house, even though don't normally go to that hospital, I would put it on file there. So just think of those kinds of things, right? And who else has it? I mean, your healthcare proxy definitely should have it, right? And then hopefully other members of your family and that kind of stuff. And then it should be in your medical record binder and on your thumb drive too.
And I'll just go ahead. And I'll just add to what Joe said. Having the documents completed ahead of time helps to take the pressure off of your family to make that decision for you. It helps with that lessening that anxiety for them, having to make decisions like that. And so, and it also prevents arguments down the road because someone made a decision that perhaps another family member felt like should not have been making that decision. And so it helps to alleviate the burden and the stress behind that. And so you made another good point about it being a living and breathing document. And so if dynamics in families change, which they do, you have an argument at Thanksgiving dinner, and you have this agent here, and you did not make that decision to change it, then that can create a problem too. And so just know that it can be changed at any time, but also making sure that is communicated and on file at the hospital where you're receiving your treatment.
How do y'all as physicians, how do y'all approach your patients about this? Do you approach your patients?
So, go ahead.
Any of y'all? Anyone?
Well, I do ask patients when I see them in the clinic if they've thought about having an MPOA or if they have it. And if they do have it, and what I have done is just get a copy of it and make sure it's scanned into their EMR. Because again, some of them have it and it's completed, but we may not have a record of it. And do you all know that you are able to find these documents if you go to the state of Texas and do a keyword search? You should be able to find some of these documents online. both of them actually, the directive and the MPOA.
I have a question real quick. Can you explain medical power of attorney?
So the medical power of attorney is the agent that you're assigning to be the voice for you to determine what type of treatment you would like to receive.
Medical power attorney is synonymous with your healthcare proxy and an agent.
Agent, okay. We were using the terms interchangeably, I'm sorry.
It gets confusing.
Yes.
And living will and, I'm sorry, and advanced directive.
Medical directives.
And
Yes.
There's too many terms, but.
So from the provider side, I think that it's important, although not frequently addressed, that you tell people what they can expect of their bodies. I think that a lot of times, not to be derogatory towards pediatric cardiologists, but frequently they don't address specifically with their patients what's likelihood of death is, because I think it's probably difficult. And I've had experiences where patients are, that's something I usually address in the first visit I have with a patient to make certain that they people know what their expectations are. People can get very upset if they've not been told before that, the probability that their heart is going to carry them to 80 is either 0 or very likely 0. And that's hard for people if they've been told their whole life, oh, you're doing great, and we'll see you again next year, and it's not really addressed. So I think before you can even begin to talk about advanced directives, somebody has to be aware of what's likely to come. And that starts the conversation, and it starts people thinking about it. And once that groundwork has been laid, then I do think it's important to address those things. I have to admit I'm guilty of not regularly addressing specifically advanced directives until people become sick, and I know that that's not the right time to be addressing advanced directives, but from the practical standpoint, that's what I've been doing. I do, and that's something that I need to change in my practice. But I think ideally you start by talking about what somebody should expect of their life, and then, as your relationship with a patient develops and progresses, then you start to address advanced directives to make sure that you're on the same page.
And can I just get a show of hands? So everybody here, raise your hand if you've had any kind of conversation at all with your family about what you want. Okay. And then let's switch it up. Raise your hand if you've never had any kind of conversation with your family about what you want. Raise your hand if you've never had any kind of conversation with your family about what you want. Okay, so, wow, you guys are pretty well educated. You're better than me, right, unfortunately. I guess
Better
one of
than
the
me.
things, I will say this, I mean, to sort of make an excuse for us physicians, I think the physician's office, especially an adult congenital heart provider's office, is kind of an awkward place to actually have the conversation. I know we like to try to, and the reason why I'm sitting next to Ashley is because she's a huge proponent for having advanced care planning discussions. And so I really want to keep getting her volunteered to enter into this discussion. But part of the reason why I think it's awkward is this, right? We are geared, just like pediatric cardiology is geared towards helping patients find the strongest way forward, whatever that case may be, the least morbid, the least invasive, whatever method we can to help them to continue to progress and expand their longevity and to optimize their quality of life, right? That is what our number one goal is. It may not be what the Hippocratic Oath is, but that's what we've been trained to do, right? So to actually turn that around and say, well, actually, if all things were to go to hell in the handbasket tomorrow, what do you really want out of life? That's kind of not really a conversation that really sort of suits the tone of the conversation that we're currently having in the office, right? So I would almost argue that it's probably a better conversation with you and your family to have. And so as I've started having this conversation with more and more patients, unfortunately, as Ari mentioned, sort of at the bedside when things are not going well, a lot of times what I've actually started helping them to understand is more of the conversation of what is it that are really the most important things in your life. So instead of thinking it from a very dreadful, terrible, oh my God, I'm going to die tomorrow. Would I, do I want to be trached? Do I want to have dialysis? Blah, blah, blah. Those sorts of things. I kind of bring it back to what are the most important things in your life? And I think this is probably a conversation that's best had with you and your family so that you can have those conversations, so you can direct your healthcare proxy in the right direction. So to follow that trail, basically, when we've talked about this in a public setting and we've talked about how to start talking about advanced care planning, we talk about what are the most important things in your life? Who do you love? What do you love? Why do you love it? What do you want? Right, because the reality is even those of us who have a great life expectancy, we don't know if that's really a life expectancy. We don't know if that's an accurate life expectancy. So it's still important for us to know what those goals are in our lives, no matter what. And that's why, as all of you guys mentioned on the panel, I think it's important that we have all had this conversation, parents, patients, caregivers, healthcare providers, with our families. And I think that that's what's going to inform the harder questions. Do I want dialysis? Do I want a tracheostomy? Do I want prolonged ventilation? Because the reality is, unless you actually already know what's important to you in life, and you're mindful about those things that are important to you in your life and in your family's lives, it's very hard to answer all those other questions. And I actually think that when you start to figure it out that way, it helps you to be a little bit more mindful about how you live your life anyway. So.
Yeah, I think that document that MD Anderson has is a great place to start because it sets up a lot of those things. And I think too that I think the role for the doctors is, at least from my perspective, is more so when it comes down to just the refinement and some of the wording as, does this document make sense? If you read this document, would you know what my wishes were? Right? Because, often I go back and I read my advanced directive and I go, I don't know if that totally makes sense. Like, that makes sense to me because I wrote it, right? But would that make sense to somebody else? And so, and that's why, sort of why I say it's a living and breathing document, because I always change it. Like, I'm gonna, edit it or whatever to make it have more clarity. But I think, to me, that's really the role of the doctors does this make sense? And we're all on the same page, right? And because it's your life, it's your wishes, and that's really where it's coming from. And the real details of it is those conversations with you and your family, right? The role of the doctor is just to play out your wishes. And so it really comes down to if the document makes sense so that, everybody can perform that one when you're not able to be there.
Just to reinforce that, I can say that the most difficult times I've had in my career in medicine have been over these situations. And so you may be crystal clear in your mind what you want to have happen to you. You may very eloquently put that down on paper and think it will be crystal clear to people who read it, but I can tell you that that isn't always the case. There's no question that many people in your family are going to try to make the decisions that they think will be what you will want. What you want them to do is to make decisions that you want, and they're not always the same thing. So the discussions that are the most difficult to have are the most important ones to have, because what happens in the most functional families is a sad time can become an angry time where people disagree about what they think, you think. So be not just crystal clear with them what you want, but also be crystal clear about who that person is that is going to speak for you based on what you have put down as your wishes.
So I'd like to add to what I think everybody is
saying. And I think the most important thing is what is quality of life for you in making these decisions. If you can define that, I think it can help you get to where you can define your wishes. Also, in addition, when I was doing some literature review, I happened to come across this website that's actually called National Healthcare Decision Day. And it's April 16. Funny enough, we do our taxes April 15. And there is a quote that Benjamin Franklin said, the two most certain things in life is death and taxes. So I think if you don't have a well-defined timeline, time point, you want to visit this conversation, I think that's a good time to probably plug in your calendar and revisit it. I think also as patients, as much as you're an advocate for your care, we want you to also be able to have these conversations with us, providers, nurses, social workers, and be able to openly have a conversation because you've established a relationship with us and you feel comfortable to do so. And that way we can guide you and help you and take you along this pathway of defining what your advanced directives are.
Write a crystal clear document and we have it on file. We have encountered, all of us, difficult situations. The family is facing hardship when they feel they're losing it. So it's hard for them to wrap around their heads with these things. So sometimes we review what you've written and we look at the date and they will say, oh, he was depressed back then. I remember that was when he lost his job and he was depressed. I'm sure if we asked him today, he would think differently. So not only talk about it often.
Yes.
And also, a lot of patients don't know what are their choices in those situations. So if you're ready to talk and we don't bring it up, because I personally, I try to stand when my patients are ready, when we have a relationship to talk about it. But if you're ready and we don't bring it up, ask questions. And you don't have to make a decision in the first day. You can think about it. You can talk on the phone and you can discuss it with your family. It's a really hard situation. Probably some parents have been taking care of the children for a very long time, and it's against the rules of nature for them to take that moment when they lose their child. And to make that decision, sometimes they should go, is really hard for them, and it's going to stick with them for the rest of their lives. So you need to help them out and be clear about what you want to support them.
Can I interject a little bit and maybe kind of throw in a provocative idea, which is, I've encountered two situations that made me pause. One was a woman in her 50s who had relatively moderate congenital heart disease, and she asked me, stared at me straight in the eye and told me, could I have had kids? I've been told before that I could never have kids, so that I adopted. Could I have had kids? And the answer, had we known at the time, yes, but probably your providers did their best. The second scenario was a very well-informed, intelligent patient who had a Fontaine, and unfortunately, for variable reasons, has not had appropriate care. By the time we saw him, immediately in my head, I was thinking, I need to start telling him about transplant. But he had already made up his mind based on social media, based on talking to other people that frankly are not just the right people to talk to. And for the life of me, for an entire year, he would not listen to me and meet a heart transplant patient. Just talk to someone, get the appropriate information. So I would say challenge your doctor. Tell them, you know what? You're giving me one answer about my problem. Are there other places who would give me a different answer? And I'm entitled to get a second opinion. I think that's something that we, as doctors, sometimes may not necessarily offer the patients. And we may not say that, you know, we don't know. There's limits to what we can do to you here or for you here.
I'll make a very practical point because everyone's talking wonderful things in grand discussions. The reality is often these discussions come up like minute 29 into a 30-minute clinic visit. And the reality is everyone has time constraints. And so it's our job as physicians and as nurses to kind of start this process. But from your standpoint, I think it's helpful for us to know this is a discussion you want to have. And start that discussion early so everyone's not rushed while you're trying to do it.
And I did print out some of the forms online for those that said they had not necessarily thought about just any of it, just so you can just look at the language and start seeing what some of that looks like. I have some of those with me today if you want to take them home with you.
I'd like to say something as a parent. We unfortunately had some losses in our family, and that started us thinking about putting all of this in place for ourselves. And so my husband and I actually made an advance directive. We did the living will and the medical power of attorney and a financial power of attorney, and then we turned to our adult sons and we said, you need to do this now. You never know if you could be in a car accident or some other kind of situation. But we led by example. And like I said before, my husband is a nurse, which is helpful because sometimes the language that is used in those forms is very confusing. And so for us to sit down as a family while everybody was well, now it's true, we were suffering the loss of a family member, and I think that's what brought it to the forefront for us. But it was at a time when our nuclear family was okay. I think it takes away some of the scariness. So if you wait until your doctor brings it up, some people get scared that if the doctor brings it up, that must mean that something's going to happen to me. So if you're a parent out there, lead by example. Go ahead and do it for yourself, and then talk to your children about, this is what I want for myself. Have you ever thought about what you might want for yourself? Not during a regular doctor appointment. I know there are a lot of people who have PTSD about going to their annual appointment. I'm afraid that if their doctor brought that up to them, it might make them even more afraid. I think it really does need to start in a family.
There we go. Yeah, I think from the provider side of what you're saying, I mean, if we think back to how medicine was practiced 50 years ago, 80 years ago, I don't know, 100 years ago, the time of paternalistic medicine, a lot of these decisions about end-of-life care, about what to do when you're critically ill, were left to the provider. There weren't that many technologies out there, but what to offer, even up to 30, 40 years ago, that was the culture of the way medicine was practiced. And for good reason, for patient autonomy, for individual human rights, it was brought back to patients. But this is incredibly confusing. It gets harder the more complex or technologies we can offer. And when we break it down into, well, there's DNR and DNI, which is one part of it, but then what about end-stage dialysis? And what about devices for your heart? And what about transplant things? And if you can't, and what degree of, of trauma from a neurologic perspective are you willing to take? And those thoughts can change. If you haven't talked about it, you will not be able to answer that question when the time comes. We talk about how to live. You're right. I am going to die at some point in my life. We have to talk about it. It's important to talk about congenital heart disease, no heart disease, acquired heart disease, anything, because it's an important reality of the human condition. And it's okay. And it's okay for it to change and be fluid, but you're right. If it is very challenging in an annual visit with somebody who's doing great with tetralogy of Fallot, where there's no concerns at this point in time and no issues, to It's very hard to have a conversation unless you've created a relationship where it fits. Out of the blue, if it comes up, so great, oh, your ASD was closed 10 years ago, everything looks great. And by the way, let's talk about advanced care directives. It doesn't fit. It doesn't fit. I mean, we laugh, but it's true. It's like the reason, it's actually really good in the inpatient side that every patient is asked these questions. You have to kind of in every hospital, and that's good. And now we're used to it. On the outpatient side, not so easy. So the initiative often should come from the patients when they're ready to talk about it. If there's times where that's not the case, there's times where you're about to offer something that's incredibly high risk, need to talk about it. You know, we need to talk about all the options, which include transplant, ventricular assist device, this surgery, Fontan conversion, which may not go well or may go well, or should we just focus on medical therapy and see where things go from there? That's some time to do it. There's a time if they're asking for it, but it's not always easy to do. And so I think we have to change the culture of society because we now have, I'm going to be a patient at one point in my life. I have been already in the past. So it's important. We have to take control of our lives, and we have to take control of how those final months, years, our medical care during that time will be. It's really important to talk.
Another thing that I've seen as probably more as an inpatient nurse, but when it comes to patients that don't have, you know, living wills or don't have a defined medical power of attorney, is that sometimes we start things and then we ask a family member, do you want to take this away? When what it comes down to is if you can have that conversation with your family and you have those documents, then whatever it is that you don't want doesn't start. And I've been on that side as a family member as well. And it, as I'm sure you can all imagine, it's a lot harder to stop something or take something away than it is to not start. And I think that that is a small gift that you can give your family, to not have to ask them to then take something away from you. Because I've talked to families who have said, well, if I turn off that ventilator or I turn off that ECMO circuit, then I'm killing him. When, you know, obviously, you know, we all know that if we hadn't started that, the patient would have passed anyway. So I think that if you look at it that way, and you know that an advance directive isn't necessarily just about life and death. It's sometimes about changing the focus from, you know, where we as, I think, as society very much function in a death is the enemy kind of mindset, when maybe we need to look at it more like suffering is the enemy. I don't think any of us would want our loved ones to suffer. I don't think we want to suffer. So I think that maybe if those two thoughts are kind of a good thing to keep in mind. And I know in my practice, I've always tried to keep that in mind, and sometimes have to remind Dr. Lynn to keep that in mind too.
Yeah, I think there's some flawed thinking in that we think, you know, old people need an advance directive, but I would argue that it's more important that young people have an advance directive because, you know, if you decided to keep me in a vegetative state right now at 37 until I'm, you know, 87, I'm going to be more pissed off than if I was 87 and you kept me in a vegetative state, you know, for till I was 93. So I think there's more at stake when you're young. So I would, you know, urge all the people, everyone, to have an advance directive. Yep.
I started working on it, but the part I had trouble with was, okay, I want to be cared for, but how do you know how long you can be in a vegetative state till the doctors just say it's not going to work? I mean, you want them to try, but then at some point you want them to not try.
So that was just a point I was going to address. All of these decisions need to be put into context. So because somebody needs dialysis doesn't mean it's keeping them from dying. There are times when we need to initiate dialysis for a week or two. And then it'll get you through what you're going through, and you can recover and go back to everything that you need to. There are times when we keep people asleep on a ventilator and keep them under anesthesia to get them through what they need to get through, which is temporary and reversible. It's very important to understand for these very important decisions what the context of those decisions need to be.
Yeah, I was gonna say, in my advanced directive, I delineate it between, I have basically called it out as a bridge to treatment, yes, I would like to be placed on ECMO as a bridge to transplantation or whatever that is, whether it's recovery, dialysis, but I don't want to be, I don't want to be on dialysis indefinitely. So those are the things, if you can have them, any way you can do that to kind of make those decisions and have them categorized. That's how I do it. I mean, I don't know if anybody else has any.
Yeah, so I was wondering if you put no dialysis or no resuscitation, does that mean that's it? Or can you put it, like you said, a bridge, but how do you word that?
Well, I mean, that's the tricky part. And going back to what we were saying, you want to be crystal clear. I mean, for me, I put, yes, I would like, ECMO as a bridge to transplantation or other treatment, or surgical, whatever, other interventions or whatever it is. I mean, I don't know that's the exact wording, but in general, that's how I do it, and then maybe and then I, also have a line item too. Yes, I want, yes, I want IV fluids and, just things that, no brainers you want.
Yeah, I just want to make a comment. Like I said, having worked with mostly infants with congenital heart disease. Once I had a little girl that was very, very sick and had been on a ventilator indefinitely with pacemaker, and the surgeon did not want to let go. And so I, as a nurse, had to be the advocate for that little baby. And I had to speak to another physician about it. And they had to do a ethics committee to let that patient go because the surgeon didn't want to let go. So we have to think about those situations when they have to die with dignity.
Mm-hmm. I think that's why it's so important family members need to speak with one another and need to make their needs known, especially once you do become an adult, because as the parent, you want to do everything to save your child, just like the surgeon wanted to do everything for that child. But I think it's important, especially once they come to a certain age, that their own wishes be known. And I think your point is very well taken, that those forms can be a little bit confusing, and the way that you feel today may be different than the way that you feel in a few years. When my sister-in-law was in the hospital, like you all said, that's one of the questions that they ask everybody. And the social worker who came in and asked her if she had her advanced directive said, every time you get a new driver's license, you should be re-examining your forms. And anytime something special happens, if you have a new person come into your family because there's a marriage or there's a birth, that's another time to take those documents out and look at them to see if things have changed with the way that you feel about things. But if you're constantly having that conversation, I shouldn't say constantly, but regularly having that conversation with your family members, then it's not a big surprise and it's not something that's dreaded. My mother became very ill. When she came and moved into my house, I said to her, we have to do this. My mother was in her 70s. You would have thought she would already have this done, and she did not, and she was very resistant to it. but she wanted me to make all the decisions for her, and I said I wouldn't do it without her sitting down and doing that document with me. And little did I know that a year later, we would have to pull that document out. But because we had had that conversation, I was able to turn to my sister and say, I know exactly what Mom wants. And my mother had also talked to my sister. And so when it came time to make those end-of-life care decisions for her, we were in complete agreement. There was no arguing. And I think that's what you want for all of your family members, is that everybody is as clear as can be. And so when you are having to make those difficult decisions, there really is no ambiguity. You know exactly what needs to be done.
And to answer your question from a physician perspective, we all went to medical school to save lives. So when these difficult conversations start at the hospital, when the patient is critically ill, when we think that the aggressive care is futile, and we are putting that patient has a very low likelihood of recovering or for meaningful recovery. So that's when we ask those difficult questions. If you are having a pneumonia and you need a ventilator, a breathing machine to get you through that infection, that's not the same discussion. The discussion is, and we will ask all the experts if this was a neurological event, we will have the neurologist give us the potential or lack of potential for recovery before we have those discussions. So all these difficult questions need to be answered in situations where the care is getting to be futile and hurting the patient more than helping.
Yeah, I would add back to your question, 'cause sort of the Texas form that they give you for the advanced directive. If you just go through that and check the box and assign your healthcare proxy, you're really leaving the huge gray area. There's not really, you haven't really done much, you know. So I would advise you to, spend some time to actually, really dive in and fill it out. And actually, there's not even enough room on that form to really do it justice. So, and if you need any help with that, feel free to reach out to me. You can, actually, if you want my email, it's joev@teamunclejoe.org, and I'd be more than happy to help you think about some of those decisions and that kind of stuff. But yeah, it's just be aware that the basics of the form are purely just the outline. You really need to think about more in depth of what the decisions are and the how are you going to communicate that.
So we've run overtime. So I just want to make sure we summarize some of the most important points that we talked about. Doctors are really bad at doing their own advanced care planning, apparently. But more importantly, one of the things that I really want to emphasize is have the conversations with your family. Have the conversations with your family about what is important in your life and what are your goals in life. Have the conversations in your family about who should make those decisions. Designate a healthcare proxy, set up a medical power of attorney, and then readdress it on a regular basis. When you're ready to have those conversations, talk to the doctor that you trust the most, whoever that might be. Okay, if it's your adult congenital heart provider, fantastic. If it's your primary care provider, fantastic. But have those conversations and continuously have those conversations. So with that, I want to thank all of you guys for coming. Give yourselves a hand. I want to thank our really fantastic faculty. Some of them had to run and catch planes home. Thank you, guys. So we haven't quite picked our date for next year, but I see a lot of people who came last year, so I see you guys are still getting something out of this. So next year, I want to invite you to invite some more of your friends, because as we all know, there's a lot more congenital heart disease around than we actually think there is. So you being here really helps the other person who you met today and the person you're going to meet tomorrow. So with that, we have my second favorite part of the day, which is ice cream outside. So go pick up some ice cream, make a friend, and have a conversation on the way home. Thank you, everybody.